Good morning and welcome to the University of St. Thomas Journal of Law and Public Policy's 2017 Spring Symposium, NFIB v. Sebelius at 5, the Affordable Care Act and the role of the federal government in healthcare reform. My name is Patrick O'Neill and I am the editor-in-chief of the Journal of Law and Public Policy. And on behalf of the membership, I'd like to thank you all for being here today. Our staff and membership have been working hard all year to put this event together, and we are excited to hear from the accomplished group of speakers we've assembled. Today, 5 years after the landmark NFIB v. Sebelius decision, we will be examining the federal government's role in the regulation and reform of our healthcare system and the future of the Affordable Care Act. NFIB v. Sebelius has been heralded as the most significant federalism decision since the enactment of the New Deal. The Supreme Court's decision upheld the Affordable Care Act's requirement that certain individuals pay a financial penalty for not obtaining health insurance as a constitutionally permissible tax, while rejecting the argument that the individual mandate was a justifiable use of the Congress's power to regulate interstate commerce. The court also held that Congress exceeded its spending clause power by coercing states into a vast expansion of Medicaid, by threatening states who refuse to cooperate with the loss of existing federal funds. The controversial decision has been the subject of a great deal of criticism across the political spectrum, and the Affordable Care Act itself is one of the most controversial pieces of legislation in recent memory. Throughout the past year's election season, calls to repeal and replace or reform the Affordable Care Act dominated political campaigns, and earlier this month, House Republicans attempted to repeal and replace the Affordable Care Act with the American Health Care Act. Today's speakers will discuss a wide range of issues related to the lasting impact of NFIB v. Sebelius and the future of the Affordable Care Act. Our goal is to encourage a respectful discussion about the constitutional, economic, and policy issues associated with the regulation of the healthcare industry by the federal government, as well as where that regulatory system is headed and should be headed. After each presentation, our speakers will field questions from the audience. Members of the journal will circulate note cards during the presentation for members of the audience to write out questions to be asked during the question and answer period. Please don't hesitate to ask questions and contribute to the discussion. Now, without further ado, I would like to introduce our first speaker, Professor Nicole Huberfeld. Professor Huberfeld is the Ashland Spears Distinguished Research Professor and Associate Dean of Academic Affairs at the University of Kentucky College of Law. Professor Huberfeld focuses her scholarship on the cross-section of healthcare law and constitutional law and federalism. Professor Huberfeld's work has been widely published, and her article, Federalizing Medicaid, was cited by the Supreme Court in the NFIB v. Sebelius decision. Today, she will be talking about the purpose of healthcare federalism. Please join me in welcoming Professor Huberfeld.
Am I on? Oh, good. I like to wander. So, am I too close? Is that better? Everybody can hear me. Good morning. Happy Friday. Happy week from the American Health Care Act failing. Keeping up with healthcare reform is sort of like running up a mountain of sand. Every time you think you get to the top, you start sinking. And it's a total moving target. And so what I'd like to do today is actually fairly ambitious for the amount of time that I have. That's par for the course for me, if you've ever seen me speak before. And so I'd like to cover this topic that I've proposed, what is healthcare federalism for? But you really can't answer that question unless you have a sense of history regarding efforts at healthcare reform in the United States. And you can't understand what NFIB is about if you don't understand the ACA itself. So I'd like to spend a little bit of time talking about historical patterns in efforts at healthcare reform. If I tried to talk about our 100 years of efforts at healthcare reform, we would be here all day. So instead, I'd like to talk about patterns. I'd like to talk about the ACA itself and how it fits within those patterns. I'd like to talk a little bit about NFIB and some of the key points of NFIB for my part of this conversation. And I'd like to share with you some somewhat failed empirical research that I attempted to do with some co-authors to try to understand empirically, quantitatively, what healthcare federalism is for in the new federalism era. And then finally, I'd like to talk a little bit about where I think we're going from here and where I think some potential pitfalls may lie. So that's the scope of my part of the conversation, and I will definitely leave time for questions at the end, and I look forward to our conversation. So, as you may be aware, we've been attempting to figure out healthcare in the United States for approximately 100 years. That's not an exaggeration. And I think it is important to understand that despite rhetoric you may hear from public officials, from people in think tanks, from others who think about these issues deeply, there is a pattern to what we have seen over time. And it's not just that pretty much every president who's attempted to create national health insurance or a national health care program has failed. We can put that out there for consideration. But also that when the federal government responds to national needs, it is because the states and markets have failed. That is the pattern that we see in healthcare reform historically. So for example, when FDR was attempting to write national healthcare into the Social Security Act in the 1930s, it was because the Great Depression showed that states could not afford medical welfare. When we saw Harry Truman attempting to create a national healthcare program after World War II, it was because the states couldn't afford to care for the impoverished and the soldiers who were returning from the war who needed healthcare. When we saw Lyndon Johnson pass Medicare and Medicaid in 1965, it was in response to prior failed attempts to incrementally change healthcare in the United States. So my argument in terms of the patterns that exist here is that typically federal intervention in healthcare in the United States is incremental and relatively minor and always with an eye toward the considerations of what the states have historically done in this field. In other words, there is typically a sense that the states should still be in the game, even if they have been failing at healthcare reform historically. So you see that in the 1950s when Harry Truman finally gets medical vendor payments passed. The federal government started giving money to the states to help them with medical welfare because the states could not afford it. But the debate as to what the role of the federal government should be and what the role of the states should be is ongoing and nothing new. It has been basically the same debate since the 1940s. Should the federal government take over if the states can't do it? What role should the states have? And in many ways, this conversation about healthcare reform reflects the very conversation that we've had through the last 100 years about federalism itself. Because we think of federalism often as lawyers from a constitutional perspective. We tend to think of federalism as serving certain values. We tend to think of federalism from a constitutional perspective as serving values such as state sovereignty, state autonomy, experimentation, variation. But in reality, when we're not thinking about the judicial or constitutional view of federalism, we see that the more pragmatic, political, statutory view of federalism is something else entirely. And so that's something that we were trying to show in the empirical work that I'll discuss with you in a few minutes. So over time, we've seen this incremental response by the federal government to the states' failures in healthcare. Every now and then, there's a leap forward. Medicare and Medicaid were a leap forward. Medicare in particular was a leap forward. Why? Because the elderly were impoverishing themselves for healthcare, and it was a known problem. When Medicare was passed, it was not a new idea. It was simply that the idea's time had come. Politically, there was a taste for it. Medicare is the only true social insurance we have in the United States. You turn 65, you get into Medicare. You become permanently disabled, you get into Medicare. That was a 1972 add-on to Medicare. Medicaid was a caboose to Medicare's train. But it, too, showed recognition that the states could not afford to pay for the needs of the poor, and that the states historically did not want to pay for the needs of the poor. There was a law that was passed in 1960 called the Kerr-Mills Act. The Kerr-Mills Act was functionally block grants to the states to pay for the poor and the elderly's medical care. If you were to take a map of the states that participated in Kerr-Mills and transpose it onto a map of the states that were first interested in participating in the Affordable Care Act's modifications of the healthcare system, it would be startlingly similar. Always, what we have seen is that the wealthier states are on the forefront of healthcare reform, and that poorer states lag behind, sometimes for economic reasons, sometimes for class-based reasons, sometimes for racist reasons, which is documented and historically true. And so it's worth thinking about all of this history when we think about why the ACA needed to be one of these leaps forward that we've seen occasionally in the history of healthcare reform in the United States. So why did the ACA look like it does? In 2008, when President Obama was elected, as you all probably remember or are aware, almost 20% of the population was uninsured. Let me see a show of hands. How many of you have blue eyes? How many of you have blue eyes? No health insurance for you. That's what it looked like. And it was about that random, except that there were known patterns. So historically in the United States, we've relied on employer-sponsored health insurance for gaining healthcare coverage. And in the United States, if you don't have health insurance, you cannot get consistent access to medical care. And so the focus has become, over time, on making sure that everybody has health insurance so they can have consistent access to healthcare, okay? But in 2008, a couple of trends became clear. And they had been known for some time, but they were particularly clear at that moment because we'd reached an all-time high of uninsurance in the modern era. First, employers providing health insurance had decreased over time. We were at a high of about 72% in around 1980, and it had drifted downward to about 52% of Americans being covered by employer-sponsored health insurance by 2008. However, the broad national numbers don't tell you everything you need to know, because we also know that the less money you make, the less likely you are to get health insurance as an employment benefit. So for people earning less than 400% of the federal poverty level, as you go on down by steps from 400% to 300% to 200% to 100%, statistically, you are less likely to be offered health insurance as an employment benefit or to be offered health insurance that is affordable at all. Further, if you're a part-time worker, the chances of you being offered health insurance are slim to none. So there was a crisis for people earning less than 400% of the federal poverty level, which happens to correspond to about the average earnings of all Americans, about $50,000. So the focus was on finding a way to get health insurance to people who couldn't get it. And that's why the ACA looks like it does. Medicare has been stable since 1965. And in fact, some people describe it as the third rail of healthcare reform. You don't want to touch it. It causes an electrical shock. You're going to get hurt. It is a very stable program. It's a very politically popular program. Medicare does have some modifications in the ACA, but fundamentally it stays the same. It remains social insurance. Employer-sponsored insurance still basically remains the same. Employers are not required to provide health insurance under the ACA, despite the fact that people talk about an employer mandate. It's not actually a mandate. If you're an employer and you employ more than 50 people and you don't offer them health insurance or don't offer them affordable health insurance, and your employees seek insurance on the exchanges and they need tax credits to purchase health insurance, then you will be penalized. So it's a tax penalty for large employers who don't offer health insurance. Who's it targeted at? Employers like Walmart, who have historically relied on Medicaid because they pay so little to their employees. So what did the employer-sponsored insurance do? Nothing changed, except that if you were an employer like Walmart, you would have to offer health insurance or face a tax penalty. Statistically, this only affected about 4% of all employers, the employer mandate. So that's not where most of the work is. Most of the work is in Medicaid and in individual small group insurance. Why? Because historically, Medicaid has only covered the deserving poor. This is an Elizabethan notion. It is the idea that you will not get assistance from the government unless you are worthy of it, which means that historically Medicaid has only covered people who are poor plus pregnant, poor plus disabled, poor plus a child, poor plus elderly. The ACA changed that. It created a new baseline. It said, if you are a non-elderly adult earning up to 133% of the federal poverty level, you can get into Medicaid. We are no longer going to judge you based on your characteristics, other than your poverty. So the ACA expanded Medicaid and made it available to everybody. Now this is important to understand because one of the points that I want to make today is that we will never know how the federalism of the ACA would have looked or worked or whether it would have been a good model because of NFIB versus Sebelius. NFIB turned the federalism of the ACA on its head. So Medicaid is federalized in some ways, and it's already a federal program. It invites the states to participate. But Medicaid becomes federalized in terms of who is eligible to enroll. Historically, the states had to cover those deserving poor categories, and then if they wanted to cover more people, they could. Minnesota was one of those states, in fact. And so what you see is that the federal government says to the states, this isn't enough. We're changing the baseline. Now everybody can get into Medicaid. But it's the same program. It's a change in eligibility. The other big change is to the private insurance markets. Now, we've seen attempts to change private insurance markets before, most notably in recent history, HIPAA. Many of us think of HIPAA as a privacy law, but in fact, HIPAA assisted people who were experiencing job lock to move from one job to the next so that they wouldn't lose insurance coverage through their employer-sponsored health insurance and they wouldn't be penalized for having pre-existing conditions. So HIPAA didn't go far enough, but it was the incremental change that came when the Clintons failed in their healthcare reform. So what do we do with the ACA? Well, the ACA makes it so that individual and small group insurance becomes much more available because historically it's so expensive that nobody can buy it. So we start to get tax credits for people earning 100% to 400% of the federal poverty level. And it's on a sliding scale, so that if you're not earning very much money at all, you get a fair amount of money to purchase health insurance through an exchange. What's an exchange? It's basically like Expedia for health insurance. You're buying a known quantity. You can compare, you can contrast. If there are options, you know what you're getting. But in addition, the ACA makes everybody insurable by doing things like preventing pre-existing condition exclusions and by enforcing things like community rating that make it so that, for example, women can't be discriminated against by insurers just because they're women. So the ACA modifies insurance on a national scale by setting standards for things like essential health benefits, by setting standards for things like community rating, by setting standards for things like pre-existing condition exclusions. And it gives people money so that they can buy private insurance. It's a boon to the private insurance industry. Now let's think for a minute about the structure of this. I said a minute ago, Medicaid eligibility was federalized by the ACA. So if we want to think about it as being either federal or state, the ACA envisioned Medicaid expansion as being federal, with an invitation to the states to participate. If we want to think about the exchanges, though, in the ACA, as it was written, the exchanges were envisioned as being state-run. And the model for that was Massachusetts. So if we're thinking about what Medicaid looked like in the ACA as written, it's federal. If we think about the exchanges, they're state. Okay? What does NFIB do? Well, lots of things. NFIB does lots of things. Why? Because this is perhaps the most complex, one of the most important decisions in recent history. We're talking about three major statutory questions. Can we have an individual mandate? Is Medicaid expansion possible? Is a statute of this size severable? And then we're thinking about 5 constitutional questions. Commerce power, taxing power, necessary and proper clause, spending power, and then beneath it all, the 10th Amendment, which is barely cited in the decision. I see Josh nodding along. So the question is, what does NFIB do to federalism as we understand it? In many ways, it's a continuation of the Rehnquist Revolution. The Rehnquist court made it clear that it was interested in judicial enforcement of the line of federalism. It was interested in the institutional power that the court holds to police the line between the federal government and the states. And in so doing, the Rehnquist court articulated for us a concept of federalism that is frankly rooted in old ideas about what the role of the states is or should be. because dual sovereignty doesn't have a lot of meaning in the modern era. Most of the federalism that is occurring now is not constitutional federalism. It's statutory federalism. Because we know that the federal government can operate in certain ways that would allow the federal government, if it so chose, to aggrandize its own power, the political branches. For example, we have known since the 1940s that Congress has the constitutional authority to regulate insurance under the Commerce Power. Congress gave that power back to the states in the McCarran-Ferguson Act in 1944. That is a statutory move. That is statutory federalism. Medicaid is another example. Medicare is much more constitutionally clean. It is a straight-up spending program. Once you invite the states to participate in that spending program, it becomes a conditional spending program, which is constitutionally messier. And that's what we see in NFIB. We see that that invitation from the statute of the ACA for the states to participate is constitutionally trickier. It is pragmatic, but it is very different from the court's vision of federalism. So the court adopts some novel theories that I suspect Josh will talk about, so I don't want to go too deeply into them. But the court, I'm not going to broccoli, you got that. So the court adopts a couple of novel theories in NFIB versus Sebelius. It tells us that Congress cannot regulate inactivity. This is a novel distinction in constitutional law, activity versus inactivity. The court also tells us that the necessary and proper clause cannot be exercised when the court has already decided that another constitutional authority is not being appropriately exercised. So in other words, though it may have been necessary for Congress to regulate health insurance, it was improper because Congress couldn't exercise its commerce power to require the individual mandate. But then the court tells us it's a matter of choice if people are going to buy health insurance, and if it's a matter of choice, then we can penalize the choice not to buy health insurance through taxes. Therefore, not saying much about the taxing power at all, but giving Congress the ability to continue along with the individual mandate, which of course is enforced by the IRS, and if you were looking for it, it's in the Internal Revenue Code. So we then come to Medicaid. And the thing about the Medicaid part of the decision is this: it makes no sense. I'm just going to put that out there for consideration. It doesn't make sense from a statutory interpretation perspective, and it doesn't really make sense from a constitutional perspective either. And in many ways, it highlights what we need to think about today, which is what is healthcare federalism for? Because the court doesn't do healthcare very well. We'll put that out there for consideration. We can talk about it. The court does not do healthcare very well. It typically doesn't display very much deep understanding of what's before it when it comes to healthcare. It's too complicated. And in fact, in oral arguments a decade or so ago, one of the justices infamously said, "Oh, Medicare, Medicaid, I can never keep them straight." That's not very encouraging. So the court decides that the Medicaid expansion is new Medicaid. It doesn't look enough like Medicaid to be part of the same program, and decides that because the states could lose all of their Medicaid funding, something that's never ever happened in the history of Medicaid since 1965, but because theoretically the states could lose all of their funding if they don't participate in the Medicaid expansion, the court says that is unconstitutionally coercive and recognizes a brand new enforceable doctrine. Now, this wasn't surprising if you were following the court on federalism, because Justice Kennedy for years had been saying, why aren't we using the 10th Amendment to limit the spending power in the way that we use the 10th Amendment to limit the commerce power? Why aren't we? So it was no surprise to those of us who'd been paying attention that the court took up this issue. The problem is they left us hanging. If we want to recognize coercion as a doctrine, we have to be able to articulate what coercion is. But instead, the court told us we'll know it when we see it. We know that didn't work out for the First Amendment, right? And here's the other thing. How can it be right that if Congress is offering to pay fully for a new healthcare program, which it was doing with the Medicaid expansion, if Congress is paying fully, how does that coerce a state? It may coerce a state politically, and I don't mean that from a constitutional perspective. I mean that ideologically, it coerces the states. And I think it's important to acknowledge that. Because the court seems to end up by saying, this expansion, it's not related enough to what came before. But it doesn't overtly acknowledge that there's a germaneness problem. And it doesn't really acknowledge that what it ultimately allows the states to do itself undercuts the court's own analysis. Because the court ultimately says it doesn't matter how much money Congress is offering, it matters how much it's going to take away. And if you remember your South Dakota versus Dole, that's a basic Dole analysis. But is that right? If Congress offered Minnesota $10 and then said, we're going to take it away if you don't fix all of your roads, Minnesota would be like, okay, because it's only $10. So it seems like ab initio, the court's analysis can't be right, because it has to matter how much Congress is offering. The more Congress is offering, the more it matters what's being taken away, right? So the court is protecting the states in the name of federalism without overtly saying so in NFIB versus Sebelius. And it ultimately says, we're not going to strike down anything from the ACA. Instead, what we're going to do is we're going to limit what the Secretary of the Department of Health and Human Services can do if a state chooses not to participate in the Medicaid expansion. But if a state wants to, it can. Now, that's probably the strongest federalism statement in the whole opinion, allowing the states to make that choice. But if you think about it statutorily, from the perspective of the Medicaid Act, it makes no sense at all. Because a state that participates in Medicaid has to submit a state plan and then a state plan amendment to HHS every time it decides that it's going to participate in any statutory change in Medicaid. Well, if the Medicaid expansion isn't Medicaid enough for coercion purposes, what's a state supposed to do if it wants to comply with the Medicaid Act, but the Medicaid Act isn't Medicaid enough for Medicaid expansion? Do you see what I'm saying? The court tried to divide up the statute, but then relied on the very statute that it said wasn't that statute. So the federalism of NFIB is a mess. Let's just throw that out there. What does it do from that basic binary federal-state perspective that I was mentioning a moment ago, talking about the ACA? It turns Medicaid on its head. It gives leverage back to the states so that they can negotiate with the federal government whether or not they're going to expand Medicaid. So whereas Medicaid expansion was federal, as written in the ACA, after NFIB, Medicaid expansion is state. But the federal government still has the enabling statute in place that says our goal is universality. So the federal government now has the goal of universality without the tools for universality. And the states are given power back, and they're told, you can negotiate this with the federal government. Query whether that really matters, because the very tools that have been used to negotiate Medicaid expansion, they already existed before NFIB versus Sebelius. Things like Section 1115 demonstration waivers, they've existed since the Social Security Act existed. So there's nothing different in the law structurally. But what's different is the attitude. What's different is NFIB. And then if we think about what flows from that, the sort of signaling spillover, the sort of regulatory spillover, we see that the states use this leverage that they gain with Medicaid to decide that they're not going to go along with the state-based notion of exchanges in the ACA. And instead, they're going to exercise federalism for federalism's sake. And they're not going to participate in the exchanges, forcing the federal government to do much more work in creating marketplaces than it ever intended to do. So both the Medicaid expansion and the exchanges are turned on their head because of NFIB, ostensibly. Okay, so where are we? What's going on with Medicaid expansion? Here's where I want to talk a little bit about some empirical work that I've tried to do to figure out what all of this really looks like on the ground. And I started thinking about this question back in 2012 after NFIB was decided, because states started deciding, there was a lot of states were holding out, as we'll see in a minute. A lot of states were holding out as to whether they were going to participate in Medicaid expansion or not, because they wanted to see what would happen in NFIB versus Sebelius. And the reporting was deeply dissatisfying to me, because the reporting, at least at the national level, made it sound like this was a binary. States were either participating or they were not. And that's true from one perspective. If a state doesn't participate in Medicaid expansion, there's no expansion in the state, and millions of people don't get health insurance. But it wasn't true from the perspective of federalism, in that states were engaged in ongoing negotiations with the federal government to figure out how they could expand and when they could expand and what they could get for expanding. And none of those negotiations were reflected in the reporting. And then I ran into a person who became my co-author, Abby Gluck, who teaches at Yale. And it turned out Abby was doing the same thing from the perspective of the exchanges. And then we ran into two friends of ours who are also healthcare heads from Penn, and they had a grant from Robert Wood Johnson to study this very thing. So the four of us got together, and we decided to try to figure this out from a quantitative perspective. But the hard part about that is trying to figure out what you're measuring if you're trying to quantify the exercise of federalism. How do you measure sovereignty? How do you measure autonomy? How do you measure variability? That one's easy. How do you measure experimentation? How do you measure whether those things are successful? That's inherently not a quantitative binary, right? It's qualitative. And so we found that it was really nearly impossible to figure out from a purely empirical perspective what was going on, because it's so much more complex than the maps show you. We had states that signed on to the expansion very early on. Minnesota was one of them. States that had already been participating in Medicaid in a robust way, maximizing federal dollars to try to expand healthcare coverage to everybody that they could. NFIB comes along, HHS issues guidance, and we see that some governors decide, this is for us, we need to take that federal money that's sitting on the table, right? So we have these sort of notable triggers in state behavior. And we see then another notable trigger is the Arkansas waiver, the first waiver that allowed a state to take its Medicaid population and put them into the exchange and let them use Medicaid dollars to buy private insurance. But what you see is that all the states, when they see this kind of movement, they want to be the last one in line so that they can get all the goodies that came before. So Arkansas is the first to get such a waiver, Section 1115 waiver. Iowa, Michigan, Pennsylvania, New Hampshire, they quickly follow. They quickly follow. But they all get something more, as I'll show you in a moment. And then, once the ACA became effective, everybody thought that would be D-Day, except that, again, NFIB turned it all on its head. That didn't become D-Day because, at that point, less than half of the states had opted into Medicaid expansion, and HHS still had the goal of universality. So HHS told the states, you can opt into Medicaid expansion at any time. You can also opt out at any time under NFIB. And so the states start to think about, well, what can I get for this? And then we see, fast forward to 2016, Indiana's waiver. Indiana's waiver was one of the major breakthroughs because Indiana's waiver is arguably the most complex and the most punitive of the Medicaid expansion waivers. It makes moves that heretofore have not been permitted in Medicaid. Now, arguably, this is because of NFIB. So if you want to know what kind of work NFIB is doing, it is still deeply disruptive to the universality of the ACA. The ACA was an attempt to get everybody in the United States insured, unless you're an undocumented immigrant, which is another conversation we can have. NFIB disrupted that principle of universality, and it is still doing so. But the federal government and the states are playing along. So we see that it's not just about these trigger moments, but also about who's a thought leader, right? It's much more complicated than who's participating and who's not, because the states are actively learning from one another to figure out what they can get in a Medicaid waiver, what goodies they can get from HHS. So they're trying to figure out, what does it look like to participate through a waiver? We know we can get premium assistance. We know that we can have enforceable premiums, meaning if you're a Medicaid enrollee and you can't pay, you can be dropped. That's new. We know that we can prevent people from using emergency transportation if it's not an actual emergency. We know that we can use some wellness initiatives. We know that we can create health savings accounts for Medicaid enrollees. What we can't do is work requirements. Consistently, HHS has been saying no work requirements because that is not part of providing medical assistance to people. It is not related to the purpose of the Medicaid Act. That's been the one major boundary that HHS drew under the Obama administration. But aside from that, there's been an incredible amount of movement, an incredible amount of negotiation, and obviously different goals going on. Because HHS, in these negotiations with the states, has been very pragmatic about the goal of universality. It has basically been willing to say, yeah, we can probably accept that so long as people get insured. Where's that in dual sovereignty? Where's that in constitutional federalism? On the other hand, the states have been saying things like, well, we want to play, but we don't want to look like we're playing. We've developed a term for it. We call it secret boyfriend federalism. Because HHS has been giving the states cover. There are many states that have given their own names to things like Medicaid expansion and participation in the ACA, right? Think about Kentucky. Governor Beshear very carefully never said we're participating in the Affordable Care Act. Kentucky created Connect, spelled with a KY, right? And Medicaid expansion was just called Medicaid. It wasn't called anything that sounded like Affordable Care Act, ACA, or Obamacare, right? So there's a lot of sort of optics going on here. HHS was giving the states cover because there's all this money sitting on the table, and it should be used for the purposes for which it was designated, which is to help people get health insurance. And states know that. But the other thing that's become clear through all of this is that the states are not black boxes. We tend to talk about the states as if they are one unitary entity. They are not. They are republics just like the United States is. And we see that different operators have different interests through all of these negotiations. That governors and legislatures may not think the same way about what they should do on any major health policy issue. It becomes even stranger when you look at what happened with the exchanges, because we tend to think of the exchanges too as a binary. And these are Abby's maps. We tend to think of the exchanges as a binary. We tend to think either you have a federally based marketplace or you have a state-based marketplace, right? So blue is the state-run exchanges, red is the federally facilitated exchanges. Everybody knows, right, we started using the word marketplace because exchange doesn't have a Spanish language equivalent that was meaningful, right? Draft your legislation carefully, people. So what does it mean for a state to move from blue to red? A state like Oregon. Oregon created its own exchange, but then Oregon's exchange failed, and Oregon had to rely on the federal exchange to keep its exchange running. Is that a federalism move? Is Oregon suddenly cooperative or uncooperative because it's changed its exchange? Some states are shifting blue to red, some are a mix. Some states have hybrid exchanges. They're not even contemplated in the ACA. That is pure, basic, pragmatic political federalism, not formalistic, constitutional, judicial federalism. The negotiations that have been happening are so different from what the court sees. It's astounding. There's this incredible disconnect. We have these state plan management models. We see the states are learning from one another. We see that states wanted to buy Connecticut's model. Connecticut was out in front. Does this tell us that we need 50 different kinds of exchanges? Or does it tell us that we'd be fine with maybe 5 different kinds? What does it mean to have a state-based exchange or a federally based exchange? From a federalism perspective, do we know if one is better or worse? Neither is inherently better or worse, but we do know that the states historically regulate health insurance. And that was the logic of Congress in allowing the states to create the exchanges in the first place. It was the idea that traditionally the states are responsible for health insurance, and so they probably have a better idea of how to make the exchanges run and how to get their insurers involved. That's pragmatic federalism. It's not constitutional federalism, right? But NFIB turned it all on its head and opened these new doors that are heretofore uncontemplated. So We see that the states have adopted one another's models. We see that the states have created models that didn't exist before. We see that HHS is deeply pragmatic in negotiating these things with the states. There wasn't enough money for administering exchanges written into the ACA. HHS just doled it out. They had discretionary funds to do it, basically. So what we see is that in some ways, although NFIB turned the federalism of the ACA on its head, it has also opened the door to viewing a totally different kind of federalism. It is much more dynamic. It is much more negotiable. It is pragmatic. We see that there is a lot of horizontal federalism going on, meaning that the states are learning from one another. Very clearly, they are learning from one another. We also see that the states, as I said a moment ago, are operating as republics. That a governor and a legislature might disagree, that the governor might agree more with the president of the United States than with his own legislature. That the commissioner of Medicaid in a given state will identify more with the goals and thoughts of the people at HHS than with other state actors. We see that alignments are important, but they're more about the job that's being done than the constitutional role of the particular actor. We also see a lot of pragmatism and creativity going on. None of this is contemplated in the very formalistic federalism that you see in a case like NFIB. There's a deep disconnect between the court's conception of federalism, especially in the healthcare context, and what has actually been happening in the healthcare context. But then we have to think about, well, what are those values again, right? What were those federalism values? We're thinking about sovereignty, we're thinking about autonomy, we're thinking about variability. Well, we know we see variability, right? I mean, look at all these crazy maps, right? That's variability. All these waivers, that's variability. Okay, so we know we get variability. But is Oregon more or less sovereign because its exchange failed and it needed to rely on the federal exchanges? Is Texas more or less autonomous? Josh, you'll tell us. Is Texas, is Texas more or less autonomous because it refused to participate by creating its own state-based exchange, thereby inviting the federal government in to run the exchange in the state? Doesn't that aggrandize federal power? Doesn't that diminish state sovereignty and autonomy? This is what I'm talking about when I say federalism for federalism's sake is an outcome of NFIB. States are making choices that don't seem to make sense from a healthcare policy perspective, but they make some sense from a federalism as sovereignty and autonomy perspective, unless you consider the outcome, which is that ultimately they're inviting the federal government in. The court's warned about this. If you think about cases like New York versus US, that was the dissent. So let me move forward a little bit and make sure that we have time for questions and answers. We attempted this quantification of the federalism of the ACA. Quantification not working. Deep qualitative analysis, yes, that's what you're seeing here, right? There's a lot to be said in the details. But where does it ultimately get us? We observe these themes in healthcare federalism, but where does it ultimately get us if the court can't see the political perspective? And I don't mean political as in let's go fight about whether we're Democrats or Republicans. I mean the pragmatic politics of the political branches, right? So what do we need? Do we need 50? Do we need 1? What we've seen so far seems to indicate that it's something in between. But 50 doesn't seem to be the right number. A person who has a heart attack in Arizona shouldn't be treated differently because they live in Arizona than if they have a heart attack in New Mexico. They both need the same medical care. I will also say, I think that this secret boyfriend federalism has invited grandstanding that would not have existed otherwise. And so this is an example from Kentucky. When Governor Bevin came into office, he decided he was just going to undo everything Governor Beshear did. So lest you think that the Trump administration is a surprise, it was all happening on a small scale in Kentucky already. Because Governor Bevin thought that the government should have no role in healthcare. He wanted to completely roll back the Medicaid expansion, and he wanted to get rid of Connect, which was arguably one of the most successful state-run exchanges in the country. And so ultimately they figured out that they're touching the third rail, and they decided instead of rolling back Medicaid, they were going to seek the most aggressive waiver ever. Now, this wasn't a surprise because Governor Pence was actually on the dais when Governor Bevin was sworn in. So it was pretty clear that Kentucky was looking to what Indiana had done. But it sets up this game of chicken. Because here's Kentucky saying, okay, we've already opted in. If you want us to stay opted in to the Medicaid expansion in particular, here are the things we want. Could Kentucky be the first post-opt-in, opt-out state? Possible. Imagine that. It will mean that hundreds of thousands of people do not have health insurance in Kentucky. More than 400,000. A lot of people. But here's the Bevin administration submitting a waiver with work requirements in it, even though they'd been rejected multiple times by HHS, and Kentucky will absolutely be the test case for the new administration. Because we know, let me come back to that, we know some things right now. We know that Tom Price, the new Secretary of the Department of Health and Human Services, basically would take us back to 1930, before Blue Cross and Blue Shield existed. He does not think that health insurance should exist. He thinks that everybody should pay cash out of pocket for medical care. I'm not overstating it. We also know that Seema Verma, who in this picture is receiving an award from Governor Pence for helping to create the waiver in Indiana, Seema Verma, and I know this from conducting some interviews last summer about what's actually happening with the healthcare federalism of the ACA. In the meetings where Indiana was negotiating with HHS, all Seema Verma could say was personal responsibility. That's her catchphrase. Which seems to indicate a couple of things. One, we have a Secretary of the Department of Health and Human Services responsible for one of the largest budgets in the federal government, responsible for the health care of 100 million people, who doesn't think that health insurance should exist, which means that he probably won't hesitate to allow variability that we haven't seen before. And we have a person who's responsible for the Centers for Medicare and Medicaid Services who thinks that personal responsibility is everything. That if you're an able-bodied adult, it's coded language, by the way, if you're an able-bodied adult, you shouldn't get Medicaid unless you can prove that you're worth it. Well, that's the deserving poor concept that we got rid of with the ACA. And this is where I think secret boyfriend federalism is a problem. Because when HHS gave states cover to expand their Medicaid programs, it made it so that the people of those states really didn't understand that the states themselves had made those decisions. And that's the very problem that Justice O'Connor pointed out in New York versus US with political accountability. If you don't know if it's the state or the federal government that's responsible for the program, how do you vote with your feet? So we now have people in charge of HHS and CMS who have a very different perspective than what the ACA itself is. And we know that President Trump has issued an executive order, he issued it on the first day in office, that is largely intended to be deregulatory when it comes to health insurance, whether it's private or public. He is telling his agencies, engage in waivers. He's telling them, give flexibility to the states. He's telling them, I support a free and open market. So I think it is predictable, whatever happens with further legislation efforts, that we will see more Section 1115 demonstration waivers in Medicaid for states that want to expand. Just this week, the Kansas legislature passed legislation that would create Medicaid expansion in Kansas. Governor Brownback vetoed it. Now they're seeing if they've got enough votes to bypass the veto. This is an ongoing conversation. But none of that is contemplated by the court. And the values of federalism do not seem to align with the values of healthcare. This is an uneasy partnership. Federal incrementalism has invited the states in time and again. We see now in conversations about whether the ACA should be repealed or replaced or repaired, we see talk about pushing healthcare back down to the states. But history tells us that is doomed to fail. There is no state that has successfully experimented with improving healthcare without both money and guide rails from the federal government. History shows us that. So where do we go from here? I did not bring my crystal ball today, but I would love to take your questions now so that maybe we can have a conversation about it. Thank you. I think we have 15 minutes, is that right?
Yeah.
Yeah.
Until 9:25. Okay, if you have any questions, please don't hesitate to pass them into the middle. Professor Huberfeld, thank you. Thank you, that was a great talk. The first question I received was, in order to increase the number of participants in a given risk pool, could states create a regional or cross-border risk pool? How does that fit into your conception of federalism?
So those already exist in the ACA. The ACA encouraged state compacts for making it so that states could work together to improve the number of insurers that were available in exchanges and to improve the networks, especially in places where people cross borders frequently. And the states have had a hard time picking up the compact part of the show. As you may be aware, states can't create compacts with each other unless Congress approves them under Article 1, Section 10 of the Constitution. And so that's what the ACA does. It gives the states the ability to create compacts with one another. But what I understand from conducting these interviews last summer with the governmental and other stakeholders in the implementation of the ACA is that the state insurance commissioners cannot get it together to work out these compacts. They don't want to give up their fiefdoms, for lack of a better way of putting it. And so, well, I think there's value in thinking about that because it's not clear to me that the states are accurate proxies for anything anymore. I think that you have to find a way to work around the sort of political siloing that occurs. And as to the cross-border sales of health insurance, I don't see why that can't happen. I mean, again, going back to what I was saying earlier, the Supreme Court told Congress in the 1940s, you can regulate insurance. Congress gave that power back to the states in the McCarran-Ferguson Act. So states historically have regulated health insurance, and they have done things like create consumer protections in so regulating health insurance. And so one of the things that people get concerned about when we talk about selling health insurance across borders is that those consumer protections will no longer be applicable once an insurer crosses a state's border. There's also some pragmatic concerns that networks will be harder to form in a different state because the insurer won't know the healthcare providers of a different state as well, and they may be less willing to participate with that insurer, so that networks would not be as robust or would be narrower. But in principle, I think that it could work to sell health insurance across state lines. I mean, in truth, health insurers are themselves national entities. It's just that we continue to force them to be licensed to be health insurers in each state in which they operate. And that's an historical anachronism. So I think it could work, but I think there are some moving parts that would have to change before it could work.
Thank you. As you mentioned, Minnesota was one of the 31 states to expand Medicaid voluntarily. Minnesota was one of the 31 states to expand Medicaid voluntarily under the ACA.
Yeah.
What would a repeal mean for us going forward?
So it depends on what the repeal looks like. So we could talk here for a second about the American Health Care Act bill if you want. Because that was a reconciliation bill, it could only involve money, either spending or taxing. And so in that bill, what you saw was a sort of soft stop to Medicaid expansion. And I say it that way because technically Medicaid expansion wasn't ended, But the super match that exists under the ACA for this 8th category of eligibility was reduced to the state's regular match in Medicaid. As you may be aware, all states get about somewhere between 50 to 80% of their funding for Medicaid from the federal government, depending on the state's per capita income and some other factors. And so the new category of eligibility was different in that at first it was 100% funding, and then it phases down to 90% funding by 2020. And so it's still a super match as of 2020, and it remains that way forever under the ACA as it was written. Under the American Health Care Act bill, that super match would end, and the state's normal matching rate would kick in for the expansion population. But if anybody leaves Medicaid and they're part of the expansion population, they can't get back in. And the trick about that is a phenomenon called churn, which is that people who are low income tend to have more highly fluctuating incomes than people who are traditional salaried wage earners. So people who have an hourly income have a much more sort of unsteady source of income, and it tends to change enough that people churn in and out of sources of health insurance. So if you have a Medicaid expansion, that means people will churn in and out of Medicaid and then ostensibly onto an exchange. And they will get tax credits to purchase private insurance on the exchange once they're earning too much to be part of the Medicaid expansion. If you're in a non-expansion state, that means that you fall into what people call the coverage gap, because the penultimate poor, the people who are the working poor, they will probably be earning too little to get tax credits because they'll earn less than 100% of the federal poverty level, but they won't be able to get Medicaid to cover it. So it's a soft stop to the Medicaid expansion because of the phenomenon of churn, because if people fall off Medicaid enrollment, then they can't really be part of Medicaid expansion anymore, but the Medicaid expansion wasn't technically ended. So what happens if we have something that doesn't look like the American Health Care Act? It depends on what the legislation looks like, because if it's a full-blown repeal, then there is no money for Medicaid expansion. Now, a state like Minnesota had a waiver to engage in what was functionally state-based expansion. And so probably a new waiver would have to be negotiated with HHS to make something like that work again. And that would be true for a state like Minnesota, Massachusetts, New York, California, states that are more robust in who they cover under Medicaid, and next to it, CHIP, the Children's Health Insurance Program. But if it's a full-blown repeal, there wouldn't be any money for Medicaid expansion. And so it would be back to the drawing board on negotiating what's functionally the same thing. Query whether that wouldn't be coercion under NFIB, right? A state that has expanded and relied on expansion and has invested administrative time and lots of state dollars in expansion, perhaps they could say, you promised us. Where's our money?
Thank you.
I have one last piece to that. This is a practical piece to it. Sorry, now you got my ball rolling.
Go ahead.
Medicaid requires that if somebody is disenrolled from Medicaid, that you have to make sure that they don't qualify for another aspect of Medicaid. So it's not an immediate full stop. In other words, let's say a single woman who's 25 gains Medicaid coverage, and while she is on Medicaid, she becomes pregnant, and then Medicaid expansion ends. She would still qualify for Medicaid because she's pregnant plus poor. So the state would be obligated to see if all of those people who had been enrolled could somehow otherwise qualify for Medicaid, but not expansion Medicaid. So the transition takes time. That's the point I wanted to make. It wouldn't just be immediate full stop.
What effect, if any, what legal effect, if any, does the president's executive order from January 20th have on the Affordable Care Act?
It has no impact on the Affordable Care Act because it's an executive order, and the executive's constitutional duty is to take care that the laws are faithfully executed. So the president can't change a law by himself. However, pragmatically, we know that there are choices that are made in how the various administrative agencies enforce any given law at any given time because there are so many laws to enforce. So a different example, if I can take a step back from the question for a moment, would be what the Obama administration with regard to legalized marijuana, right? We know that marijuana is a Schedule I drug under the Controlled Substances Act. We know that as part of the war on drugs, the federal government has prosecuted people who are simply users of marijuana historically, not sellers, but users. But the Obama administration said, we're not going to prioritize this. We don't really care to use the resources of the DEA and other federal agencies in such a way that they will be seeking marijuana users out. We are more interested in stopping the flow of heroin into the country and other choices. So that is executive discretion to execute the laws, right? And so what you see in the executive order constitutionally has no value, but pragmatically is an instruction to HHS to think broadly about what the ACA does or does not require. And so that's why I think it's not that hard to see that there could be, for example, more aggressive demonstration waivers granted for Medicaid expansion. The other thing that can happen from an executive order like this, and is already happening, is a question mark over whether people have to be forthcoming in the reporting of having health insurance on their tax returns. Because when the administration is signaling that they're not interested in the law, people gain a sense that they don't necessarily have to be so honest about whether they are complying with the law. Now again, that is a more pragmatic concern, but one that I think is worth mentioning. So the executive order doesn't have particular legal effect, but I think it has pragmatic effects, if that makes sense.
Thank you. And if anyone in the audience just wants to raise their hand and ask a question, that's fine too, just so you guys know.
You have someone over here.
It's a little bit of a complicated concept, so hopefully this correctly transmits my question. How much money has NFIB cost in terms of increasing inefficiencies in delivery of medical care and costs incurred by citizens not covered by medical insurance that would have been covered without the limits imposed by NFIB?
What?
So inefficiencies in the delivery of medical care throughout the states by forcing the negotiations of the different kind of agreements, but also there's a cost to the citizens and to the overall economy because citizens aren't covered by medical care. Some citizens would have had medical care if NFIB hadn't been decided the way it was.
Right.
Right? So
right.
There's a cost there, and
yeah.
there's also the cost of the inefficiencies.
Yes, okay. So are you asking how NFIB disrupted the economic scheme of the ACA?
Right, and if it's quantified.
Yes, yes. So it's actually fairly straightforward to quantify it. There's a fair amount of literature now on what Medicaid expansion has achieved in a number of vectors. And I would turn you to the Kaiser Family Foundation has done 2 summaries of the literature. They've done 2 literature reviews. They just posted an update. So Kaiser Family Foundation, kff.org. And so what you see from the literature is that in the states where there is Medicaid expansion, in other words, the ACA it was as it was intended to be, there are notable economic benefits. Because another aspect of the ACA that many people are not familiar with because it's sort of technical is that the ACA decreased disproportionate share hospital payments. And DSH payments are payments to hospitals that treat more charity care patients. And the ACA decreased these payments with the idea being there would be fewer patients who were not covered by insurance, and so therefore hospitals wouldn't need that filler for charity care, right? So in Medicaid expansion states, what you see is the economic benefits of the ACA operating as it was intended to. You have more people who are covered, you have insurance covering more procedures, you have more people getting coverage at a moment that they need it, rather than waiting until it's so bad that instead of controlling the diabetes, you have to amputate the foot, right? So you see that there's this sort of initial surge of cost because when people get insurance and they haven't had it for a while, there's this moment of sort of taking care of the things that need to be taken care of. But that surge then flattens out on the individual level. On the collective level, when we're thinking about institutions and the kinds of effects they've seen from the ACA, there are a couple of different things to think about. There's the way that the finances work out in terms of people being covered by insurance, which makes it much easier for healthcare institutions and providers to budget themselves because they know what their sources of payment are going to be. They know what their payer mix is instead of having a bunch of charity care patients, right? But then also, it shores up the healthcare industry in tangible ways. They can employ more people to care for more insured patients because they know payment is more certain, right? They can build better facilities. They can ensure that they have ambulance services that cover rural areas that would not necessarily have had coverage before, right? So there's this sort of spillover effect that stabilizes and improves the economics of the healthcare industry in a given state. In states where there has been no Medicaid expansion, studies show that the problems that existed at the moment the ACA was enacted are still problems in those states. So the problem of uninsurance leading to high bad debt loads for hospitals, and now there's less money coming from the federal government for disproportionate share hospital payments, and so those hospitals are really suffering. Hospitals in particular are suffering. And the reason I focus on hospitals is because they tend to be the institutional actor that kind of acts like the canary in the coal mine for healthcare. Physicians are not that because they are not obligated under the law to treat anybody. Hospitals are obligated under federal law, if they accept Medicare's reimbursement for their services, which is most hospitals, to, under EMTALA, treat anybody who shows up in the emergency room. So hospitals sort of act as that canary in the coal mine. They show us what's going on economically in the healthcare system. And so there's a clear difference in expansion states and non-expansion states. I'm not sure if that answers your question. Okay, is there a piece that I'm missing?
Well, if it's been quantified, I mean, it would seem that there is a significant cost to having sick citizens, and you have inefficient delivery of services when they have to go to an emergency room. Right? So I was just looking for more, some kind of hard numbers, that NFIB would have cost, because it's difficult. There's so many moving pieces, right? So it's probably, maybe it's impossible to come up with a number. It's conjecture at best.
I don't think it's been evaluated in the way that you're framing it. But the obvious outcome of NFIB, right, the way that you can quantify it is to look at states that expanded Medicaid and states that did not. Because that is the obvious outcome of NFIB, states not expanding their Medicaid population, right? So that's how the scientists tend to think about it, the social scientists tend to think about it, right, is what is it that's quantifiable here? You can't really quantify the outcome of a Supreme Court decision unless you know what pragmatic effect it has, right? And so that is the most obvious pragmatic effect. The other thing that happens, of course, too, is that if you have a lot of uninsured people in a given area and they are using your emergency departments, those hospitals have to seek payment somewhere other than disproportionate share payments. And so this is one of the justifications that Congress put forth for creating the individual mandate in the first place. We know, we can quantify that insurance premiums increase when there is more bad debt in the hospitals in a given area, because those hospitals then turn around and negotiate better payments out of the private insurers, and the private insurers in turn pass it on in the cost of premiums, right? And so there are some studies as to that. Again, it is about the non-expansion versus the expansion states, because that's where you get these big gaps in coverage. And so you see that it's harder to measure that, because unlike the Medicaid expansion, exchanges do exist in every state. So there's some stabilization of insurance markets and premiums because of the exchanges and what they've done to individual and small group markets. So it's harder to sort of separate out what role non-expansion of Medicaid has had in things like increases in private insurance premiums, because there's so many stepping stones in between. Does that make any sense? Yeah. Thank you.
Okay, we have time for one more question. Does anyone have one final question?
Sure. So given what you're saying, I'm struggling to understand what would motivate a state politician, say a governor of Kentucky, to either reject federal expansion of Medicaid or reverse it. I mean, is it just politics? Is it just ideology? I mean, it seems to me that it's a no-brainer. I mean, if you can get 400,000 more people of your citizens insured, that's a great thing, you know, especially if the federal government is paying for a bulk of it. I mean, what motivates these people?
I think Josh is going to talk about that, but I think, frankly, it is important to acknowledge that there are different views of what the role of government should be, right? And you can't discount that in this conversation. There is a view that government should step in and help people when they need help. And there is a view that government should do as little as possible, right? And it is hard to reconcile those two views. And it is especially hard to reconcile those two views when it comes to something like healthcare. Because it is very concrete that a person who is walking down the street and has a heart attack is gonna need healthcare for that heart attack. But people surrounding that person having the heart attack are gonna disagree as to who should help that person having the heart attack. And so I would be hesitant to say it's just politics, because to a degree there is political theater that's been going on, right? That led to the development of the secret boyfriend federalism model, right? Because states wanted cover to show that they weren't really participating, but they were taking advantage of the ACA, right? We have always had this debate. That's why I started with the history of healthcare reform. I mean, really, since FDR, we have had this debate. What is our responsibility to our fellow citizens? Do we have any responsibility to fellow citizens? Do we have any responsibility to pay for their healthcare if we can, recognizing that one day we may be that very person? And there's a very pragmatic economic aspect to that, which is the biggest risk pool is the entire country, right? If you really want the cost of insurance to come down, get everyone into the risk pool. And everyone means everyone. So you can argue it from a political perspective, you can argue it from an ideological perspective, you can argue it from an economic perspective, you can argue it from a health policy perspective, but at the end of the day, we have almost opposing views as to what the role of government should be. And that's what's at play here, but it's always been at play in healthcare reform. And you know, Governor Beshear, he commissioned studies by Deloitte and other firms to show that the economics of the ACA were worthwhile for a poor state like Kentucky. And those are publicly available documents. And what Governor Beshear told me was that governors talk to each other about these things. I had a chance to interview him. The governors do talk to each other about these things. And they show one another ways to achieve what they want to achieve. But at the end of the day, if you can't get all of the politicians in a state on board, you can't make it happen. So that's why I say we shouldn't think about the states as black boxes, because they operate as republics too. It is both a very simple and a very hard question. But I suspect you knew that.
Thank you, Professor Huberfeld.
Thank you.
We're now going to take a quick 5-minute break. Please be back. Welcome back. Shh.
See, that works.
Welcome back. It's my pleasure to introduce Professor Josh Blackman from the South Texas College of Law. Professor Blackman specializes in constitutional law and in the United States Supreme Court. He's an adjunct scholar at the Cato Institute and the author of 2 critically acclaimed books on the legal challenges to the Affordable Care Act: Unprecedented, The Constitutional Challenge to Obamacare, and Unraveled, Obamacare, Religious Liberty, and Executive Power. Today, Professor Blackman will be discussing the saving construction at 5 years. Please join me in welcoming Professor Blackman.
Thank you. Thank you. It's a pleasure to be here at St. Thomas. You are very fortunate. Nicole is the leading scholar in this area, so you've gotten off to a great start. I don't know how I'm going to follow that up, but I will do my best. It's hard to believe that the Obamacare decision is now 5 years old. My young legal career has more or less tracked the ACA. I was a law clerk as I was going through the courts. Shortly after the case was decided, I started teaching. About a year later, I published my first book on Obamacare. A year later, 3 years after that, I published my second book on Obamacare. And here we are, still talking about this case. What I'd like to do today is walk you through not just the 5 years since NFIB, but the beginning of the ACA and conclude with some thoughts of how the court's decision, in particular the saving construction from Chief Justice John Roberts, has aged. And Nicole talked at length about how the Medicaid expansion has not aged well. Neither has the saving construction. And indeed, if you're interested to read more, pick up a copy of my book. My first book, at least, Unraveled. Oh, I get confused. I'm used to selling the other book. This is unprecedented, the constitutional challenge to Obamacare. So the ACA is indeed a story of how all three branches of our government collided and intersected between the legislative branch, the Supreme Court, and the executive branch. And they collided over the meaning of the Constitution. But this is not merely a story of constitutional law. It is also a story of healthcare and healthcare finance and economics and how to provide health insurance to as large a number of people as feasible while complying with the U.S. Constitution. So our story begins, I won't go quite as far back as Nicole did with FDR, but I will go back to the Clintons. Now, most of you in this room are not old enough to remember this photo. Some of you may be. In the early 1990s, 1993 give or take, President Clinton assigned First Lady Hillary Rodham Clinton to chair a task force to reform our health insurance system. And this task force came up with a plan, right, called the Health Security Act. It would have given virtually every American access to health insurance in one form or another. This was, as Nicole would have put it, a huge step forward, perhaps, from the old status quo. But as you all probably know, this bill went nowhere fast, in large part due to a series of commercials known as the Harry and Louise ads. People who are over the age of 30 are smiling, so remember this. These were commercials that were airing on TV nonstop. I remember them when I was young. They were airing nonstop in the 1993-94 period. And the setup was this. You had a ma and pa sitting at home, Harry and Louise, and they were reading this voluminous healthcare plan. And the setup was this. You know, I like my doctor. I like my insurance. I want to keep it. I don't want the government getting between me and my healthcare. These ads were devastatingly effective. If you look at the popularity of the ACA, both before and after, the Hillary care, both before and after these commercials, it plummeted. And in fact, Bill Clinton and others acknowledged that these commercials were a key driver in the downfall of the healthcare bill. And ultimately, the bill was never even advanced. It died in Congress. But that was not the end of the push for healthcare reform. Indeed, many people learned their lessons from this. And one of the lessons they learned is that if you want to reform health insurance, you have to promise people they can keep what they have. Whether or not you can actually keep that promise is a different story, but you have to make the promise to get across the goal line. But the project of reforming health insurance stalled throughout the Clinton administration. President Bush 43 had some stuff with prescription drug coverage, but the idea of national healthcare reform didn't move too far until the inauguration of President Obama in 2009. Now, some of you may recall that the 2008 presidential election had very differing views on health insurance and healthcare. Candidate Hillary Clinton, she ran twice if you recall, candidate Clinton proposed a healthcare plan that had a cornerstone known as the individual mandate. The individual mandate would, as you can guess from now, require individuals to have insurance. If they fail to, they have to pay a penalty of some sort. President Obama, during the campaign trail, opposed this. He said making people buy insurance is like making a homeless person buy a house. Ultimately, though, after Obama secured the nomination, he changed his mind and said, you know, Hillary was right about that. And shortly after he entered office, his administration, which was mostly staffed by Hillary people, started pushing forward Clinton's plan to reform health insurance along these lines with this individual mandate as the linchpin. And the bill became known as the Patient Protection and Affordable Care Act. No one says patient protection. That's dwindled away. Now it's just Affordable Care Act, ACA, or affectionately, Obamacare. And indeed, that name has become so instilled. One of my colleagues said, don't put the word Obamacare in the title of your book. No one will be calling it that in a couple of years. Okay, they still are. So we'll see for now. The healthcare policy, I will leave to experts like Nicole and others, so I won't even touch that. My focus will be on the constitutionality of this bill, and in particular, the law's individual mandate. As the ACA was being debated throughout the summer of 2009, feels like a lifetime ago, a movement began to arise, opposing the ACA not merely on policy grounds, but also on constitutional grounds. You may have forgotten about them. I haven't. They're the Tea Party. This was a very influential social movement at the time, when Trump is probably trying to kill at the moment. But in theory, it was a very influential social movement at the time that railed against Obamacare, not only because they thought it was bad policy, but because they thought the law was a violation of individual liberty. And I appreciate the last question asked Nicole. She handled it with her usual poise. There's a philosophical divide that's very hard to explain to people who perhaps don't see arguments made on both sides. But the notion of the government making you buy something was deemed odious to a huge, huge portion of the American populace. And the notion of expanding government's role in health insurance through this mandate was considered illegitimate and an improper role of government. So it's not merely a question of how do we get health insurance to the most number of people. It's how can we do it consistent with certain values. And this question, the American people said, in large part, hell no. The values were quite different. And this movement grew and grew and indeed grew. I was by chance in DC on March 23rd, 2010. God, it's 7 years ago. My God, 7 years ago. I was there by chance walking around, and there was this massive Tea Party surging on our nation's capital. And they were chanting, kill the bill, and Nancy, Pelosi, right? It was surreal seeing all these thousands of people. And I'll never forget, I saw this one sign. It said, overturn Wickard v. Filburn, right? Tea Partier, probably didn't go to law school. I couldn't have told you what Wickard was before law school. Overturn Wickard. So there was a strong constitutional current among this movement that centered on this mandate. But it was to no avail. In the Senate, after the election of thank you very much, Al Franken, there were 60. The people in this building could have switched that election. The number of people in this building was that close, really. So after Al Franken's election was settled, Democrats had 60 votes, and the decision was made, Republicans will not help us with this bill, let's go it alone. That was a fateful decision. So on December 24th of 2009, the Senate Democrats voted on a version of the Patient Protection and Affordable Care Act. The bill was nearly 2,700 pages. Did anyone except Nicole actually read the entire thing? Probably not. In fact, Senator Max Baucus, the chairman of the Finance Committee, said, I don't read bills. I pay people to do that for me. Thank you, Senator. But the bill was passed. This was not meant to be the final version of the bill. The idea was pass a Senate bill, then we'll pass a different House bill, then we'll have a conference and we'll iron out all the details. That was not to be. After the death of Senator Ted Kennedy, Senator Scott Brown, a Massachusetts Republican, they do exist, was elected into office. And with that, the Democrats were in a tight spot. See, all that conference between the houses to iron out the kinks and make this the perfect bill as it can be would never happen. The House was more or less forced to pass the Senate bill with some slight modifications made through the budget reconciliation process. But these changes on the scale of things were actually fairly small. For example, Nicole mentioned before the exchanges or in marketplaces, if you will. The Senate bill said states can create them. The House bill said there's going to be one federal marketplace. Most people thought the House bill would prevail on that, so there would not have even been a role for states to have marketplaces. No matter. Because of Scott Brown, the Senate bill was what we had. So really, the ACA, the bill we have, right, this vaunted bill, was a draft. It was not meant to be final. And if you want to have proof of that, look at the case of King v. Burwell. They may have fixed some stuff up. In any event, John Boehner could do nothing, and the bill was passed in the Senate. Let me show you the slide. Here it is. The final bill, March 23rd, or was it 22nd? 23rd, 2010. I like focusing on this slide for a minute because this also explains the ideological divide, right? The question was asked, how can it be that so many people oppose giving health care to people? It's not just the state level, it's at the federal level, and there's a profound philosophical disagreement. Politics is a huge part of it, no doubt, but I do think there's a philosophical divide. Not a single Republican, if I move it quick enough, I get a little zero going, right? Not a single Republican supported the repeal, supported this law. Indeed, 34 Democrats crossed the aisle against it. But for the huge majorities, huge you could say, the huge majorities of the Democrats in the House and the Senate, we would not have an ACA. If a couple more of you voted for Norm Coleman, right, we would not have an ACA. But indeed, this is how society goes. As we've been told, elections have consequences. So it goes to the president. It goes to the president, and the president signs it. And he said something to the effect of, you know, the battle over healthcare reform is over. Not even close. Not even close, my friends. Within 7 minutes, that's all it took, of President Obama signing the ACA into law, lawsuits were filed across the country challenging the constitutionality of the law. The first was filed, I said 7 minutes later, by the state of Virginia. By the state of Florida. Another suit was filed by the state of Virginia. What did they allege? They alleged that the mandate was unconstitutional. So let's do a mini constitutional law lecture. I mentioned earlier the case of Wickard v. Filburn. This is actually farmer Roscoe Filburn. He lived in Ohio. He grew wheat on his farm. And he grew a quantity of wheat that was not meant for shipment in interstate commerce, wouldn't even leave his farm. He grew this wheat for himself and his families. So actually, as a side note, he was probably lying. The amount of wheat he was growing was far more than any cows could actually eat. He was almost certainly selling in the black market. But let's put that aside for now, right? Those facts were not convenient to uphold the New Deal. Nicole's nodding, right? If you had the number of acres he was growing, he could not eat that if he tried. So, but let's pretend they're the facts, right? I got Nicole nodding, good. So, the court said, even though the wheat he was growing was not destined for an interstate marketplace, the fact is that economic activity had a substantial effect on interstate commerce, and thus Congress could reach it under both its commerce and necessary and proper powers. This is an opinion by Justice Jackson. Everyone knows Jackson Youngstown. They forgot he wrote this one too. Not his finest moment. But the court says you can regulate economic activity, even if it's purely intrastate, that has a substantial effect on interstate commerce, black letter law. So where does that leave the mandate? Well, we have another case I want to talk about. This is Angel Raich, right? She was the lead plaintiff in a case called Gonzalez against Raich. She suffered from advanced tumors and required the use of medicinal marijuana to treat herself. Under California law, medicinal marijuana is perfectly lawful. Perfectly lawful. Under federal law, as Nicole stole all my thunder, it's not. She sued the federal government saying, look, I'm using locally grown marijuana, like the stuff you get at Whole Foods, right? Local pot, to cure my ailments, right? This case was actually argued by Randy Barnett, who's my co-author on a number of projects. This is Angel on the phone learning that she lost the case. Supreme Court ruled against her, and they said, look, Congress has the power to regulate this economic activity of growing marijuana. And Justice Scalia concurred, saying, even if this is not an economic activity, there's a regulatory scheme, drug enforcement, and as a necessary and proper incident to enforce that regulatory scheme, they can reach her local conduct. So these are the two major precedents we have leading up to the NFIB case. And virtually all law professors in the country, and I can count on maybe one hand, they all are the Vol conspiracy, who said otherwise. But the consensus was, of course, Congress can regulate a marketplace that affects billions of dollars and hospitals and doctors and medicine. How is this not commerce? How is this any less commerce than growing marijuana or growing wheat? And then came my least favorite piece of food. In fact, because of this case, true story, I can't eat broccoli anymore. When I look at broccoli, I think of John Roberts and I get this awful taste in my mouth. So I've forsworn broccoli. I can't eat it. You think I'm joking, being entirely serious. I never liked it before, but I have a reason not to like it. Me and George H.W. Bush. But the question became, could Congress make you buy broccoli? The argument was this. In all these other cases, Wickard, Raich, the court spoke of classes of economic activity, whether it was growing wheat or growing weed, right? There was an economic activity, a class of activity. And if you go and read those opinions, Scalia and Raich, the word economic activity, classes of activity, appears over and over again. So the insight was this. The court's precedents only discuss economic activity. What if at issue is not economic activity, but as perhaps Stewie Griffin would say, economic inactivity? The decision not to buy something. Once you buy something and you are in the stream of commerce, that's where it comes from, by the way, stream of commerce. Once you buy something and you're in the stream of commerce, Congress can regulate the hell out of you, right? Or heck, sorry, Miss Christian School, I'm sorry. Congress can regulate the heck out of you. I have to remember where I am sometimes. But can Congress shove you into that stream of commerce? And once they put you in the commerce, then they can regulate you. That was the question in NFIB. Could they make you buy something and then regulate you? This was a question not addressed by the previous precedents. Perhaps you think this distinction between economic activity and inactivity is manufactured. Read the cases, it's there. Read Raich, economic activity. So can they make you do this? Can they make you buy a product? This was the argument, right? The case was litigated through the courts. The first lawsuit I'll talk about was filed by Virginia Attorney General Ken Cuccinelli, and the federal court ruled in favor of Virginia, finding that Congress lacked the power to regulate inactivity. The second opinion, though, by Judge Vincent in Florida, this was the big one. He ruled that the mandate wasn't constitutional, as was the entire law. You could not separate the mandate from this intricate, like a Swiss watch, right? You can't just take out one gear, the major gear, because the entire thing will fall apart. So now you had two federal judges adopt this economic, non-economic theory. This case goes on to the courts of appeals. You had this dueling battle between Neil Katyal, who was President Obama's Deputy Solicitor General, and Paul Clement, who was George W. Bush's former Solicitor General. And they argued this case in court after court. The Sixth Circuit, where I clerked, ruled in favor of the government. Judge Jeff Sutton, a conservative, had a funky opinion, but he ruled for the government. The next case up was the 11th Circuit Court of Appeals. This was the Florida case. The Florida case, in a joint decision by Judge Dubina and Hull, ruled for the challengers. And with this, we had a circuit split. On to the Supreme Court we go. The Fourth Circuit ruled for the Obama administration, and in a quirk, one judge ruled that this is a tax. Now, I haven't mentioned the tax too much, but I'll get to the tax later when I talk about John Roberts. Don't worry, we're not done with that. At this point, Solicitor General Verrilli had been appointed, and the case will be argued before the D.C. Circuit. The D.C. Circuit ruled in favor of the government. So now we had three courts ruling for the government and one court ruling against the government. This was a circuit split the court had to take. But I want to pause for a moment and talk about Judge Kavanaugh. Judge Kavanaugh was a Bush appointee, a former Anthony Kennedy clerk, former White House counsel. And Judge Kavanaugh's opinion was strange. It was based on something awful called the Tax Anti-Injunction Act. Okay, what is the Tax Anti-Injunction Act? Unfortunately, you came here for con law. I'm going to give you tax. As I'm sure all of you know, April 15th is April 17th this year is fast approaching. If you have a dispute over your taxes, you have one option. You pay your taxes, and then you sue for a refund. You cannot go to court and challenge your taxes at the outset. If you did that, you could imagine people would never pay their taxes. They would just sue all the time. So there was an argument that the Affordable Care Act's mandate was not actually a penalty premised on the Commerce Clause. Instead, the argument was this is a tax. But there's a problem with this argument. If indeed the ACA's mandate was enforced by a tax, it was not yet ripe. No one would have had to pay it until 2014. Back then, when the suit was brought, no one had paid the tax yet. So the usual answer is there's no jurisdiction. Dismiss the case for lack of jurisdiction, come back in a couple years when someone actually pays his tax. Initially, the Obama administration actually asserted this argument in court. They said these cases are not ripe, dismiss them, bring them back later. But there's a problem with that argument. I want you to think about this for a minute. What if Barack Obama did not win re-election and, President Mitt Romney said, okay, screw it, right? This hasn't gone into effect yet. It never will. The Obama administration needed to defend this in court now. But this created a bizarre inconsistency. If indeed it was a tax, and you can justify it under the Constitution's taxing power, the tax had not yet been enforced. And how can you sue for a tax that's not yet been collected? This, my friends, were the seeds of John Roberts' saving construction. And the person who planted those seeds most forcefully was Brett Kavanaugh. Judge Kavanaugh said like this, look, okay, right, it's not actually called a tax in the statute, but we could treat it as a tax, and that would make it constitutional. Right? This idea of treating it as a tax and changing a few words here and there is the premise of the constitutional avoidance doctrine that I'm sure many of you have studied in your common law classes. Right? This was the basis of how the president would start smiling a lot more. So the case goes to the Supreme Court, argued before the 9 justices. This was a president who, for those of us with short memories, a president who clashed with the court early and often. You may recall that at the 2010 State of the Union address, shortly after the Citizens United decision, the President Obama made some remarks where he said that the Supreme Court has overturned 100 years of precedent with Citizens United. Not true. The Supreme Court has opened up the floodgates for foreigners to spend in elections. Not true. Right? This was our old fake news, right? He basically was lying about the Supreme Court to their face. Unfortunately, Justice Alito was sitting there with a camera on him saying, not true. Not true. Right? He wasn't actually wagging his finger, but it's a funny gif, right? But not true. So again, for those of us with short memories, we've had presidents be pretty harsh to the court in more direct forums. So this president had already asserted that he would not cow to the Supreme Court. I got more than 5 minutes. I've been up here 24 minutes. Thank you, though. Yeah, thank you, though. We started a little bit late. He's nodding. So the case was argued, right? The case was argued before the Supreme Court. As you know, there are no cameras allowed at the Supreme Court. And as a result, because there are no cameras, the only way of getting in is to camp outside the court, to actually sleep outside. For those of you who've never done this before, I've done it several times, these sprinklers come on at 3 in the morning. 3 in the morning. It's a very nice wake-up call. In fact, the big problem now is paid line waiters. This is actually a serious issue where fairly wealthy people pay homeless people to sleep outside and get them seats in the court. The court, it's true. The court has clamped down this practice, but it still goes on quite a bit. But indeed, the case was argued, and it was like a circus on the scene outside the Supreme Court. If you've never been on argument day, you should consider going. And the 9 justices would hear a record, or at least in modern times, of 3 days of oral arguments. On day number one, the Supreme Court would hear about this Tax Anti-Injunction Act, right? How could it be that a tax that's not yet been collected can be challenged in court now? On day number 2, the court would hear arguments about the Commerce Clause, right? Could this mandate to buy insurance be justified as the Commerce Clause? Day number 3 was a double header. In the morning, the question was, if the mandate was unconstitutional, could it be severed from the rest of the law? And in the afternoon, Nicole's question, which she addressed, and I'm going to skip because she did such a good job, was about the Medicaid expansion. Day number 1, the government had a fairly strange position. And so follow me here. The government argued, ready for this, ready for this, ready for this? There is no individual mandate. What? There is no individual mandate, the government said. Rather, there's merely a tax on going uninsured. What's the difference? Follow me here. If indeed there was a requirement to buy insurance, the government realized they were on pretty shifty grounds because there's never been a purchase mandate before. But instead, there have been lots of taxes on people who did absolutely nothing. So indeed, there was precedent to say you could tax something that was an activity. That was okay. But the problem then arose is, if indeed it's a tax, how can we challenge it now in court under the Anti-Injunction Act? So here is, I think, the genius of Verrilli and his other arguments. Roberts didn't make this up. He just adopted it from the government. Verrilli said this. Ready for this, guys? Ready? Let me take a step back. For purposes of the Tax Anti-Injunction Act, it's not a tax. It's a penalty. But for purposes of the Constitution, it's a tax and not a penalty. I'll do one more time, sleight of hand, right? For purposes of the statute, it's not a tax. And for purposes of the Constitution, it is a tax. The same provision, the exact same provision, depending how you look at it, is and is not a tax. Now, again, this is not an insane position, right? From a statutory perspective, in theory at least, not that we thought about it, but Congress can characterize stuff however they want. But from a constitutional perspective, it's for, I suppose, the courts really, right? The courts decide what it is. And this was the premise of the argument. This was John Roberts' saving construction. The notion that the exact same provision could be both a tax and not a tax at the same time. And this was how the court saved the law, right? Go through the arguments. By the way, moot court tip for all of you, do not drink water before you start making an argument. Don Verrilli, the U.S. Solicitor General, took a sip of water before he went up, went down the wrong pipe. So he was up there choking, literally and figuratively, as he was beginning his argument. In fact, the RNC made this fairly misleading ad where they doctored the audio to make it seem like he was choking a little bit longer. But there's like a 6-second gap where it's like, Mr. Chief Justice, may please, not quite that, but that's the idea, right? So don't drink before you eat it. So Verrilli had a pretty rough go on the Commerce Clause. The court did not seem to be buying it, but the taxing power argument really, for him, saved the day. So let me move forward. And of course, Justice Scalia asked about the broccoli horror. Can Congress make you buy broccoli? Another reason why I cannot eat the damn thing. But we move forward to the very end. After the case is argued, everyone thought that Justice Kennedy would be our swing vote. But indeed, it was Chief Justice Roberts. Chief Justice Roberts breaks my heart every June without fail. I didn't know yet how he would break my heart. This was the first time. But ultimately, the Supreme Court would rule on June 2012. And the Chief gave us his saving, okay, now I'll take 5. Thank you. And the Chief gave us his saving construction. The general idea is that even though Congress did not actually enact this law as an exercise of its commerce power, to save the law, we will treat it as if Congress had enacted a law pursuant to its commerce power, to its taxing power. We will save the law. For the Anti-Injunction Act, it's a penalty. For the Constitution, it's a tax. For the rule of law, it's a sham. The difficulty with the chief's opinion, and I'm going to focus on something that most people don't care about, but actually matters quite a bit to me, is what does it mean to be a tax? Congress has fairly limited authority over taxing, and this is the question going back to the 1790s, right? We have an income tax. This is not an income tax. You can have certain types of excise taxes, like on whiskey, right? This is not really a tax on buying something. You can have something called a direct tax, right? But those have to be apportioned by population. The Constitution has fairly strict rules over how taxes are imposed on people. So what kind of tax is this? Is it an excise tax? Is it an income tax? Is it a direct tax? This is a major constitutional question, a question the Chief Justice ignored. So in his zealous attempt to avoid the constitutional question of the tax and the commerce and other business, he basically made something up. My friend Ilya Shapiro calls this the unicorn tax. It's a tax never before seen, they'll never before seen again. So my antagonism to the Roberts saving construction is not even about the Anti-Injunction Act. I've gotten over that part. I can't get over the taxing power of the Constitution. You made it up, John Roberts, admitted. The Solicitor General put like 3 or 4 sentences in his brief on this point and basically said, yeah, it's a hard point. So the entire opinion's a sham. It is. You don't avoid one constitutional problem by creating another. You don't. That's not how it works, right? You don't read a statute in the least plausible way such that it raises a very serious constitutional issue that has plagued us since the Hyleton case in the 1790s. Right? This is like John Jay was on this case, right? This is an old question that Roberts, with a lick and a prayer, dismissed. That's not constitutional law. And I think the way to understand the Chief's opinion, we really have to go a couple years later to the King v. Burwell decision, which I talk about in my second book, which I will show you the cover of in a minute, called Unraveled. The Chief Justice in the King v. Burwell upheld a reading of the statute that the government wanted. I won't get into the details. But the Chief said the purpose of the ACA is to improve health insurance, not to destroy it. And we will read the statute in that fashion. Statutes are complicated. They don't have single purposes. They have lots of purposes, federalism among others, right? The dissent by Justice Scalia, which would be his last dissent delivered from the bench. I'm closing up, don't worry. The dissent from Justice Scalia, which would be delivered from the bench, his last dissent delivered from the bench, criticized the Chief Justice. And you could tell a lot of the Scalia oomph from NFIB spilled over into the King dissent. And he said, this court has now twice saved this law. We should perhaps call it not Obamacare, but SCOTUS care. And Scalia wrote about the Chief's opinion, it seems that we are now applying a special set of rules for this new law. And perhaps one day this law will achieve the status of perhaps the Social Security Act or the Taft-Hartley Act or others. It's only 5 years old, 6 years old, whatever it was at the time. But for now, the guiding principle of the ACA is that the law must be saved. And that the Chief Justice has decided, for whatever reasons, and you can ask me about it during Q&A, that this law must be saved. So after 5 years, the saving instruction, my friends, has not aged well. There's been no effort to defend it. I haven't seen anyone actually agree with it as a matter of constitutional interpretation that reconciles the taxing power. And it, I think, shakes the Chief's commitment to being this neutral arbiter. I think his concern for legitimacy and institutionalism trumps his own commitment to the Constitution. And for that, we are all much worse off. Thank you very much for your attention. I welcome your questions. I hope you buy my book even, but I'll start with Q&A. Everyone's leaving. My God, I scared them away. Okay. They have class. Oh. All right, questions.
Thank you, Professor Blackman. And if anyone has questions, just feel free to raise your hand and I'll hand you the microphone. To get things started, you touched on a little bit, like what kind of tax is the individual mandate? Do you believe that the NFIB decision expanded Congress's tax power?
I think he ignored it. Really, if you go to the chief's opinion, hold on, I wrote a thing about it. If I can read it. The chief's opinion basically pretends that this issue doesn't exist as well. It's not a direct tax and it's not an excise tax, but we won't tell you what it is. I'm not really exaggerating. It's not law. It basically spends maybe a paragraph or two talking about this tough constitutional issue without any analysis. The Justice Scalia's dissent calls it the lick and a promise accorded to it, right? The government's opening brief dedicated 21 lines to this issue. The government, in fact, called it an excise tax in its brief. This is not an excise tax. We have a Michael Stokes-Post in the room. Michael, is this an excise tax?
I think it might be characterized as
Really? Okay, we'll talk about this over lunch. But I do not. Roberts did not say it was an excise tax. He ignored it. Right? There were cases from the 1790s about whiskey and carriages and like, can you put taxes on those? This is not a tax on purchasing a product. It's a tax on not purchasing a product. But I don't think this is any kind of constitutional tax. This is why I think the saving construction cannot be saved. I'd be persuaded if Roberts had said it was an excise tax, I'd at least buy it. But he wasn't willing to rock that apple cart.
Can you describe why choosing self-insurance or to not have insurance and then pay for your medical care out of pocket is not economic activity?
Right. This was the government's main argument. I think it's actually a pretty decent argument. The argument's this: choosing to go self-insured is a form of economic activity because you're choosing to pay for health care later versus now. It's like a shifting base example. And under the necessary and proper power, Congress can choose to say, no, we don't want you paying for it later. We want you to pay for it now. And the necessary and proper means of accomplishing that is through the mandate. Here, I think the second part of the court's opinion, which I didn't mention but will now, is important. We often think of necessary and proper as this monolith. It's not. Go back to Chief Justice Marshall. I get them confused sometimes. I think of them on a similar level. Not good. Chief Justice Marshall in McCulloch v. Maryland, who said necessary and proper are not indeed the same thing. You could have a law that's necessary, that is read useful, but indeed not proper if it's some sort of great and substantive power. This is the tail that wags the dog theory. Will Bode has written about this, where even if Congress finds it useful to make you buy insurance to address this issue of self-insurance, it's not a proper means because you're intruding onto the sovereignty of the states and indeed the people. Right, this is an argument advanced by Randy Barnett, among others, but there's a sovereignty issue, going back to our philosophical question, but making people do stuff, make people buy stuff. And this is something Congress has never before done. And I would truly, humbly submit that it is not a proper exercise of federal power to make you buy something just to make this market work more efficiently. And on this point, there were 5 votes, and I think that they were exactly right. Who else? No one else? Oh. You go ahead. Go for it. I'm here.
Are there any other taxes on inactivity similar to the individual mandate?
I don't think so. I can't think of any. I mean, there's no reason there can't be one, but usually taxes are imposed on some sort of purchase of a product or income. Usually people, and you have the income tax amendment, but yeah, I mean, I don't know, Nicole, I can't think of any. Michael, I'm drawing a blank. Yeah, I didn't thought of. Yeah, I mean, but not in this sense where the idea is if you go for a certain number of months you're not insured, you pay a tax or a penalty. I can't think of anything quite like that, so direct.
people who put energy efficient windows also taxes.
Mm-hmm.
Robert said the majority opinion you could do not do the windows.
Not that I can think of.
Thank you. Professor Paulson?
just to be a little bit provocative. No,
Always.
I hate Obamacare, but actually am persuaded by the tax power justification. But at least the issue is very close. So here's a question for you. Could the executive branch, in its independent power of constitutional interpretation, decide that notwithstanding the Supreme Court upholding Obamacare, that it would decline to enforce it on constitutional grounds?
Oh, such a good question.
Does Professor Blackman have a view on that?
Oh, such a good question. I think actually Nicole alluded to the take care clause before as well. Follow up on that. So as a matter of policy about Obamacare, I'm ambivalent. People don't believe me, but I really, truly am. I don't write about policy, economics, delivery of services. I don't concern myself with this. My opposition to Obamacare is that the law is unconstitutional. And I think Roberts was right before he was wrong, right? A president has a duty to take care of the laws are faithfully executed. He takes an oath to the Constitution, not to the laws of Congress. Indeed, laws passed by Congress are the supreme law of the land, so long as they don't violate the Constitution. It's often said that the Supreme Court has a monopoly on interpreting the Constitution, and that whatever John Roberts says is the supreme law of the land. As any of you who study constitutional law knows, that's actually not the case. 5-4 decisions one way can go 5-4 the other way. West Coast Hotel v. Parrish is perhaps a beautiful example. Brown v. Board said Plessy was wrong. League of Cities reversed, Garcia reversed League of Cities, right? Yeah, I flipped it. Yeah, I flipped it, sorry. You have 5-4 decisions, even with Harry Blackman changing his own mind. The notion that a decision of the Supreme Court is the supreme law of the land is wrong. It's not. Cooper v. Aaron maybe said it was, but that's not right. So if, I don't think President Trump's read the Constitution, but let's say President Cruz, right? President Cruz has said, you know what? I think that John Roberts was wrong and that the Obamacare penalty is unconstitutional. I will not enforce it. I think it would be unpopular. People would lose their heads and run around like little chickens, but Lincoln, right? Lincoln didn't like Dred Scott. He thought it was wrong. He's not going to listen to it. If it was Lincoln owned no slaves, so it couldn't possibly apply to him. But he encouraged people saying, Lincoln, Tanya's opinion doesn't apply to you. It's a really tough question, and Professor Paulson is a leading expert on this issue, but this is the notion of departmentalism, that other departments of government have the power to interpret the Constitution. So I don't think the president can enforce a law that's unconstitutional. And if in his independent judgment he reaches that conclusion, contrary to the Supreme Court, there's little the Supreme Court can do to stop him. They really can't. The better question, though, is what if the president decides to not enforce the law because he doesn't like it? That's what we've been seeing the last few years. Long before Secretary Price considered suspensions, you had Secretary Sebelius and Burwell. And as I've noted in other writings, the Obama administration has declined to enforce large swaths of federal law, not just marijuana law. They haven't enforced the individual mandate. They haven't enforced the minimum coverage requirements. They haven't enforced the employer mandate. They've spent money that was never appropriated. This law is a litany of violations of the separation of powers. Another reason why I can't stand it. It's been an absolute train wreck for the rule of law. People have gained insurance. I'm not going to argue with you there. But from a legal perspective, this law should make us all feel a little bit dirty about the way it was done. True.
We have time for one more question. Otherwise,
man,
seeing no takers.
Wyatt House, what's going on? What? No good? Take a question. Thank you. From the saving construction? Yeah. Well, I'll answer your question on both a small and large scale. On a small scale, the chief wrote his opinion gerrymandered to very specific facts. It's hard to see how his commerce saving construction applies to anything else but a purchase mandate. He thinks he's so smart. I've yet to see evidence of this, but he's like, oh, let me write this perfect opinion that will apply nowhere else but make me feel good about myself, right? The Medicaid expansion part that Nicole talked about, that's a biggie. And the spending clause very well may impact the current sanctuary city debate. So perversely, all the people who opposed the Medicaid expansion part of the opinion will now rally and rush themselves and drape themselves in the opinion. You know, the same states that opposed it will now savor it. In terms of the necessary and proper clause analysis, that also may impact the sanctuary city debate about whether exercises of federal power are both proper as well as necessary. I'm in the weird place where I think, yeah, these laws are unconstitutional, right? I like federalism no matter where it leads. Not everyone's so consistent. From a macro perspective, though, the Roberts decision, I think, was a body blow to the rule of law in that no one actually bought it. Supporters of the ACA didn't really care because their law survived, and opponents of the ACA thought they got cheated. This is an opinion that satisfied no one. And if you watch the presidential debates in 2016, at least the Republican primaries, candidate after candidate after candidate railed against Roberts as a way not to be a judge. If you notice, they want judges like Scalia and Thomas, not judges like Roberts. And people, I think, recognized the opinion for the weakness it was. If I may even bring a little bit more forward, had Merrick Garland been confirmed, right? Good job, John Roberts. Your long game worked out really well. Good job with the long game. You'll be in dissent for the next 40 years. Mazel tov, right? All this long-term strategery is premised on a stasis that does not exist in reality. In the words of Hayek, Roberts suffers from a fatal conceit that as a mastermind, he can make these long-term plans and put these little seeds and plant them, these time bombs. Give me a break, right? You have held the law twice, own it. And he is. And I think his decision in King v. Burrell made that fairly clear. But this was not a neutral application of any sort of saving construction. This was something far different. Good?
Thank you very much,
Thank
Professor
you all so
Blackman.
much.
Okay, we're now going to take a break. Please be back by 10:30. We're running a little bit behind, so please be timely. Thank you very much.
Did it work as well? No? All right. Our next speaker is Zack Buck. Zack Buck is an assistant professor at the University of Tennessee College of Law, where he teaches healthcare finance and organizations and healthcare regulation and quality. Before joining the University of Tennessee, Buck attended Miami University, Ohio, where he earned his Bachelor of Arts with distinction. He then went to continue his education at the University of Pennsylvania School of Medicine, where he earned a Master's of Bioethics. Buck completed his education at the University of Pennsylvania Law School, where he earned his JD. Buck's publications include Furthering the Fiduciary Metaphor, The Duty of Providers to the Payers of Medicare, Enforcement Overdose, Healthcare Fraud Regulation in an Era of Overcriminalization and Overtreatment, and his forthcoming work, The Cost of High Prices, Embedding the Ethic of Cost in Work, or in the Standard of Care. Buck is also a regular contributor to the Bill of Health, Harvard Law, Petrie Flom Center blog. Professor Buck will be speaking to us today about the chronic challenge of cost control. Please join me in welcoming Professor Buck.
Thank you, Derek. And thank you all for having me. First of all, I'd like to congratulate the Journal on a wonderful symposium topic this year, a topic that is probably the most current and newsworthy symposium ever, I think, right? But of course, considering this is the focus of much of my waking hours, scholarship, and teaching, I may be biased, but I thank you for bringing together stellar voices to have this conversation and congratulate you on providing a platform for such a vital topic. In my talk, I'd like to move beyond a focus on the ACA or specific health insurance reforms and widen the analysis a little bit. Instead of focusing on the constitutional law implications of recent litigation surrounding the Affordable Care Act, I'll be focusing on one of the most daunting health policy challenges facing the American healthcare system in 2017. Nonetheless, recognizing that the symposium originally focused, of course, on the impact of NFIB, Even though we've had a few things happen this month, I'll be sure to wrap the case into my later comments. But in my estimation, the debates of the day focused both on the recently abandoned American Health Care Act, or AHCA, and the battered and embattled Affordable Care Act, or ACA, avoid global discussions of the American system as a whole. And it is these that are the focus of much of my scholarly research, particularly the challenge of the cost of healthcare. And in some ways, the way I see it, the reform debate has been co-opted. Instead of talking big, or I guess bigly, hashtag bigly, right, about existential challenges within American healthcare, the extended health reform debate has focused instead on the ACA's, quote, government takeover. This debate has replayed now for 7 years and has been focused on the effectiveness of websites, on the increasing amounts of premiums in the individual market without discussing the scope of other coverage expansions within the Affordable Care Act, and the debate regarding, of course, whether Obamacare and the ACA are, in fact, the same thing. Even following the collapse of the AHCA effort, national media characterized the failure as a political failure of the Trump administration, while noting that Obamacare was still tenuous. But these debates and narratives obscure the entirety of the ACA, and particularly on the importance of the law and reform effort holistically. Sure, individual markets are struggling, including my home market of Knoxville, Tennessee, but generalizing that the entire law is failing is not only misleading, but it's untrue. This is the law that establishes the rights of 26-year-olds to stay on their parents' plans, that outlaws pre-existing condition discrimination, that provides funding for evidence-based medicine and fraud and abuse enforcement, and seeks to provide free preventive and contraceptive care to everyone. I grant that the ACA is complicated and nuanced, and some pieces aren't as successful as anticipated, but by focusing on the political fights over websites, we've allowed some of the ACA's strongest attributes regarding cost control to flounder. As a result, we've left millions of Americans unaware of the good that the ACA is doing and has done in their lives, largely until recently. And in this environment, it is impossible to have productive policy debates focused on our big problems. Nonetheless, it is true that the failure of the ACA to, quote, break through and provide tangible positives in citizens' lives of which they are keenly aware is also a real critique of the messaging of the law and something worth considering during this new debate. Which brings us to the AHCA, a plan which in the end had few supporters. Indeed, the AHCA focused its energy on shrinking two things, notably changing the individual marketplace and fundamentally altering Medicaid. Specifically, the debate focused on whether 24 million Americans by 2026 who have been insured under the ACA should be kicked off their health insurance plans, whether Medicaid should be fundamentally remade to incorporate work requirements and cease being an entitlement program for many of the nation's poor, and whether healthcare reform as a policy matter can even work without an individual mandate. As you may have guessed, I thought these reforms under the AHCA were misguided and doomed to fail, and indeed they did in the end last week. But from a policy perspective, an individual market without a mandate will produce sicker, more expensive insurance pools. Medicaid without secure funding will result in deep cuts in coverage and access, essentially changing a program that has become a lifeline for many. And capping the tax subsidies given to those who cannot afford insurance will result in fewer people signing up for coverage, resulting in more expensive premiums and more uninsured individuals showing up to the nation's emergency rooms. As the New York Times stated, the AHCA was a, quote, bill in search of a problem, and that it reflected, quote, no shared vision of what it wanted to achieve. Its reforms were likely to worsen health coverage, access, and outcomes. Perhaps it was the newest attempt at delivering a death blow to Medicaid, which covers more than 70 million Americans and pays for nearly half the births in this country every year. But it, like so many health reform efforts before it, never made it into law, nor even to the upper chamber of Capitol Hill. Given the omnipresence of these debates, we can talk about arguments over the reforms and the potential threats they create. But for the remainder of my talk, I want to speak about the other larger challenge I see, and this is the challenge of cost of healthcare within the US. First, by larger, I don't mean more consequential, particularly for the millions of Americans who are at risk of losing insurance under the AHCA. Instead, I mean a cost challenge that is so daunting that it looms large in the current reform effort and likely will inhibit the success of any healthcare reform effort in the US. Indeed, it has hamstrung the ACA as well. And this is because the pricing and utilization challenges in the US swamp the ability of health reform efforts like the ACA and AHCA to achieve real cost control. If one could imagine the cost challenge as a chronic condition, after sustaining a number of body blows, the ACA treats the symptoms of the condition with limited impact on the cost of healthcare, at least so far. Indeed, the AHCA would have exacerbated them. But in order for an American healthcare reform effort to find political purchase and truly stick, I submit that the underlying condition of cost must be directly and forcefully addressed. Besides being complex, what makes the cost challenge so daunting is that there is seemingly little political will to address it. Just last year, stories of the prices of Mylan's EpiPen, Martin Shkreli's Daraprim hit the national news and sparked outrage. Americans, even with insurance, still too often face surprising healthcare bills after coming home from a hospital stay. And employers face increasingly difficult decisions about coverage for their employees. But none of these stories and pressures have resulted in congressional action in Washington. Instead, the rising prices of healthcare have been blamed on the ACA. Indeed, American families and small business owners squeezed by premium increases are covered in the media as the losers of health reform. As a result, the larger debate then centers on the wisdom of the ACA or its replacement, and not on the fundamental problem, that American healthcare is simply too expensive. No amount of tax subsidy or increased access is going to address that problem. If we really are serious about healthcare reform, we need to stop ignoring the elephant in the room, to paraphrase David Wallman in the context of drug pricing, that prices are too damn high. And where the ACA sought to make inroads in cost control, unprecedented hostility has wounded it. So now onto the cost challenges. We've heard about them before. Americans spend about 18% of our GDP on healthcare, totaling well over $3 trillion each year. We spend the most per capita on healthcare of any country in the world by a far margin, and far outpace our peers in the United Kingdom and Canada, which both spend just under 10% of their GDPs respectively. Expressed in per capita terms, we spend about $9,000 per year per capita on healthcare, whereas Switzerland spends about $6,700, Germany about $5,100, and Australia less than half, $4,200. This is not a new challenge, but America's expenditure crisis has intensified in recent years. As recently as 1980, America spent just 8% of its GDP on healthcare. This number rose in the 1990s and the 2000s. In short, it is a crisis that has sharply intensified over the last 35 years. And what makes it a cost crisis is that it is eating into other goods and services Americans can purchase and fund, like education or defense or travel. Of course, you could say, what else would you want to spend 18% of your GDP on? And indeed, it would be one thing if we were all paying for the best healthcare outcomes in the world. But unfortunately, as I've written about before, this increased cost does not translate into increased quality. America still lags behind on a number of key quality metrics compared to our peers. According to recent data from both the OECD and the Commonwealth Fund, the United States is below average on life expectancy, above average on infant mortality. We're 28th in the OECD average on life expectancy out of 44. Another survey, the Commonwealth Fund, ranks 11 countries' health systems. A survey published in 2014 by the fund noted that the US health system, quote, underperforms relative to other countries on most dimensions of performance, end quote. And the survey had America ranked last on its quality metrics, just as it did in 2010, 2007, 2006, and 2004 in all previous iterations of the survey. Recent studies have also concluded that America has few practicing physicians and doctor consultations per capita compared to the OECD average. And of course, without adequate numbers of physicians, particularly in primary care, the underlying problem intensifies. There are two contributors to the expenditure challenge that lead to the fiscal crisis facing American healthcare: utilization and pricing. Utilization is due to administering too much healthcare, and pricing is due to the fact that the costs of our healthcare services, drugs, and equipment are largely unregulated and excessive. In short, in the United States, we perform too many surgeries, administer too many tests, and intervene too frequently, and much of what we do is too expensive to begin with. Both utilization and pricing are to blame for the crisis. On the first point, American healthcare is dogged by overutilization, which I've written about before, or overtreatment, to which it's frequently referred. In trying to explain why the American healthcare system administers too many healthcare services, one could examine numerous causes. It reminds me of reading about a question researchers asked upon finding that individuals in the Cleveland metropolitan area had stents placed at 4 times the national average. Right? The question is why? Why is this happening? Well, it's complicated, but a number of the causes can be isolated. Perhaps it's reimbursement incentives, or malpractice litigation, or defensive medicine, or demanding patients, or fragmented healthcare delivery systems and medical siloization, or expensive technological advancement. Personally, I think all probably play a role. Historically, America has been unable, first, to adequately pressure physicians to care about cost efficiency. And even more than that, has inexplicably built a reimbursement structure through Medicare, at least historically, that has incentivized overtreatment. Over 50 plus years, when providers have performed additional tests and arguably unnecessary surgeries, they have sought to earn more in Medicare's fee-for-service reimbursement regime. Further, providers have been pressured to perform additional screens on patients who may have a complicated presentation due to a fear of malpractice litigation, and because the patient is demanding it, and honestly because medicine is hard. And when providers are faced with a patient who presents complicated problems, they may want to double check. Uncertainty causes anxiety, and anxiety seeks a definitive answer to a complicated medical problem. Paraphrasing author Shannon Brownlee, a provider seeking a definitive answer is likely to rely on additional screening machinery, especially if the patient wants it, rather than trusting her gut, even though it is the case that it often is her gut that was right all along. American healthcare is persistently fragmented and siloed. Providers are financially incentivized to specialize further and further. That is, the specialties that require additional training and work often are the most financially lucrative. American patients often see a number of providers without having adequate primary care. Indeed, the country faces a shortfall of 64,000 physicians in 2020. As a result, care is often duplicated and wasted. Inefficiencies permeate the system. Finally, somewhat counterintuitively, technological advancement leads to overtreatment as well. Hospitals that have recently acquired expensive top-of-the-line machinery feel compelled to use it to pay for it. The more they acquire, the more they have to use. And this is borne out by the numbers. In the surveys that I mentioned before, America does well at screening for cervical cancer, for instance, but terrible in treating childhood asthma, reflecting great screening capability, which is highly expensive, but poor primary and preventive care, which is largely inexpensive. In addition to the overtreatment challenge, which largely drives excess cost in government insurance program of Medicare, American healthcare is hamstrung by astronomical costs because the prices of healthcare in the United States, that is the initial prices of drugs, services, and hospital stays, are more expensive in this country than anywhere else in the world. Recent reporting by the New York Times, particularly work by Elizabeth Rosenthal, has shined a light on this problem. For example, in her recent reporting, she's noted the average of a couple of interesting surgeries and compared prices. The average colonoscopy in the US is $1,200, it's $600 in Switzerland. The average hip replacement in the US is over $40,000, where in Spain it is $8,000. The cost of a prescription of Lipitor is $120. In New Zealand, it is $6. An American angiogram costs $900. In Canada, it's $35. An MRI in America is $1,100 on average, and then in the Netherlands, it is $319. In addition to the international differences, pricing between and among hospitals, even some in the same region or community, varies wildly. even without any seeming regard for quality or for service. Even more inexplicably, the opaque pricing structure within American healthcare actually often leads hospitals to charge those without insurance more, at least initially, as they do not have the benefit of the insurance company's discounts. There are a number of examples of perverse pricing within Medicare's reimbursement structure that I mentioned. For instance, in a recent paper, I discussed pricing differences between two drugs, Avastin and Lucentis, both drugs that treat age-related macular degeneration, or AMD. Millions of Americans are affected by AMD each year, and as a result, of course, many of them are elderly Americans, as a result, Medicare covers both drugs without limitation. Interestingly, both drugs, Lucentis and Avastin, are manufactured by the same company, Genentech, and after numerous studies, both have been found to be basically clinically equivalent in their effectiveness against AMD. The only difference, besides one difference, one of the drugs is FDA approved for AMD treatment. The other one is used in an off-label manner, but has become the standard of care drug for AMD. The only other difference, of course, is their price. Avastin is $50 per dose, and Lucentis is $2,000 per dose. After discounts, Medicare pays about $26 for Avastin and about $1,900 for Lucentis. This is according to the Washington Post. This is an unfortunate enough development, of course, but Medicare makes it worse. Under Medicare's Part B reimbursement scheme, because the drugs are administered in doctors' offices, Medicare pays ophthalmologists the average sales price of the drug plus 6%. It's known as ASP plus 6. As a result, doctors who rely on Avastin can make about $3 on the administration of the drug, whereas doctors who rely on Lucentis can make about $120. That's 3% or 6% of the $2,000. A CMS effort to change this reimbursement mechanism in the waning days of the Obama administration was recently abandoned. Vitally, this reimbursement scheme not only financially incentivizes doctors to rely on the most expensive drug for their treatment, of course, for their patients, which is why it's no small miracle that 56% of ophthalmologists choose the cheaper Avastin to treat AMD, but it indirectly incentivizes drug companies to price their drugs even higher than they otherwise would. Finally, in healthcare, the power of the consumer is nearly non-existent. Patients do not reliably act like consumers and operate at a pervasive informational gulf. As Mark Hall has called it, they are boundedly rational in nearly every aspect of a clinical scenario. On top of this, they're often in pain or frightened. Indeed, in no other industry could a consumer expect to not know the prices of the goods he purchases before being charged. The American healthcare system, then, is both uniquely expensive and generally mediocre. And although the debates over access and insurance status dominate headlines today, little attention has been paid to these universal cost and quality problems. But that's not to say that reforms in this area haven't been attempted and succeeded. One look no further than March 23rd, 2010. Indeed, by striving for universal coverage, the ACA tried to address the cost side of the equation, and particularly the cost problem posed by two unique challenges: cost shifting and negotiating leverage, which we've talked about previously in the Q&A session. First, the ACA attempted to address cost shifting, which by many accounts is a driver of excess pricing. Cost shifting stands for the reality that hospitals will charge those with insurance more to cover the costs for those who come to the emergency room without insurance. Under the ACA, if all individuals are covered by insurance, even if that insurance is Medicaid that has a relatively low comparative reimbursement rate for hospitals and providers, then hospitals would not have the incentives to cost shift, or at least not to the levels that they do when a substantial percentage of the population is uninsured. If the ACA succeeded in extending coverage universally, then, theoretically, the cost-shifting impetus would have been removed or sated, and the prices of healthcare would have theoretically dropped or at least stabilized. Second, the ACA sought to address the negotiating leverage problem. One of the challenges of the American system is indeed its fragmented nature. By forcing millions of Americans into an individual marketplace through the individual mandate, the ACA was broadening its risk pools and deepening its coverage, which, in the grand scheme of things, gives insurance companies more leverage in negotiating rates with hospitals because the company represents a larger network of beneficiaries. For example, if insurance companies represent a substantial chunk of the market in a given state, then those insurance companies typically have more leverage in their negotiations over prices with hospitals. Hospitals must be willing to deal, and the discounts steepen. The negotiation over prices that insurance companies pay often boils down to who has more leverage, the hospital or the insurance company. When more individuals are represented by the insurance company, then it often has more leverage. Adversely, when the hospital has market power, prices rise. This is borne out by numerous studies, most recently a study published late last year by the Healthcare Pricing Project, which found that hospital prices in monopoly markets were 15% higher than those in markets with 4 or more hospitals, and that shouldn't be surprising. Further, when hospitals merge, prices increase. Because America's healthcare industry is rapidly consolidating, there is a concern over the fight to control costs. According to Deloitte in 2014, quote, if horizontal consolidation continues during the coming decade, likely only 50% of today's unique health systems are expected to remain, and that was in 2014. Of course, the consolidation of the marketplace has made the pricing problem worse. And this is where NFIB versus Sebelius comes in, ruling that the individual mandate was a tax and thus permissible, but that the Medicaid expansion was unduly coercive, again, whatever that means. Chief Justice Roberts both saved the ACA writ large, but wounded its operation, particularly as it relates to cost control, by allowing states to opt out of Medicaid expansion. In this opinion, the court not only limited the operation of the ACA, but it destroyed one of the ACA's main tools to globally control the cost of health care, and that was its effort to address cost shifting that exists in the system. With more people uninsured in states that did not expand their Medicaid program, the cost shifting problem was not addressed in those states. This was exacerbated by the proposal to cut other funding to hospitals, like Professor Huberfeld mentioned, disproportionate share payments, although some of those cuts have been delayed. Nonetheless, in many rural parts of the country, the NFIB decision has hastened the downfall of hospitals, facing tremendous budgetary shortfalls, putting in place a future of decreasing federal subsidies and limited increases in insurance coverage in states that do not expand Medicaid, particularly in my former home state of Georgia. I don't think it's worse anywhere else. 8 rural hospitals closed over the last 3 years. As a result, the solution to the cost shifting problem was blunted in these states, and cost shifted continued unabated. From a health policy perspective, this is the ultimate result of the Medicaid decision in NFIB. And indeed, politically, the Affordable Care Act has suffered because of rising premiums and unsteady individual marketplaces. But again, had parts of the law been funded as intended, perhaps these marketplaces would have been more functional. As an example, an important part of the ACA was known as the Risk Corridor Adjustment Program, whereby HHS from 2014 through 2016 would spread the risk among insurers who participated in the marketplaces at the end of each year. This was seen as a safety net for insurance companies in case they took on patients that ended up being riskier than the pool average and more expensive than anticipated. Nonetheless, Congress blocked the HHS from making these risk corridor adjustment payments and ultimately permanently stripped them from HHS discretion. As a result, for instance, HHS paid only about 12% of promised risk corridor payments in 2014. And as a larger result, health insurance companies now are suing. Moda Health scored a big win in February of 2017 in the Court of Federal Claims, alleging that they were due payments under the risk corridor program. These moves by a hostile Congress, in addition to the continued unprecedented consolidation of healthcare markets, perhaps this last phenomenon even hastened by the ACA, which we can talk about in Q&A, have intensified the cost problem, and it has continued to impact patients. The ACA has sought to instantiate other reforms that do address the rising cost of healthcare. It pushes hospitals to form ACOs, where providers and entities share financial risk and are incentivized to achieve cost savings within their systems. It's sought to arm patients with more consumer-based information, with Physician Compare and Nursing Home Compare and the Physician Sunshine Payment Act, which publicizes payments between pharmaceutical companies and physicians. Indeed, by covering preventive care, the ACA seeks to avoid the down-the-line expensive consequences that currently face too many uninsured Americans. It is, to quote law professor James Kwok, quote, significantly better than nothing. However, as Kwok argues in his blog piece, The Problem with Obamacare, the ACA is a model that utilizes private markets to expand coverage and relies on broad market-based solutions like, for example, increased cost sharing through raised deductibles to deter overuse and risk adjustment provisions to keep insurance companies participating, but that as he ultimately says, quote, Obamacare is a historic attempt to make the best out of this basic conundrum. We are trying to use markets to distribute something that at the end of the day, we don't want distributed according to market forces. And due to unprecedented hostility, the NFIB case, the widespread confusion over what the law does, and the complexity over the subject itself, the ACA's attempt to incorporate market-based solutions, along with dependence on the private insurance industry to play, leaves it unable to adequately address America's cost control problem, and as a larger result, perhaps, continued to be politically vulnerable. It is a step in the right direction, but only a step, as fragmentation, overtreatment, and excessive pricing continue in the American healthcare enterprise. As a result, monthly premiums will rise, not just for those newly insured on the exchanges, but those Medicare beneficiaries who pay premiums and those covered through their employers as well. So at bottom, in my estimation, healthcare reform efforts must address these bedrock cost concerns. Without adequate attention to and focus on them, along with a particular focus on actions that are taken to destroy real efforts to limit cost growth, reforms that cover additional people, that kick up tax subsidies, that try to insulate further Americans from feeling the pain of the cost of health care will be increasingly ineffective and, as a result, politically tenuous. And so this is, I guess, a call to action for law in this area. It's time for the law to intervene. Until American voters and legislators come up with bold new ideas to fix fragmentation that continues to dog the markets, to make more robust antitrust efforts to better address consolidation, to institute price ceilings or all-payer rate-setting laws, or public options or single-payer plans to hold down the price of rising prices of insurance. Until this happens, prices in American healthcare will continue to rise. And without concerted intervention, even with other reforms, whether under President Trump or his successor or successors, these cost pressures will continue to threaten leaders' political success, how the reforms are perceived by the public, and the quality and sustainability of American healthcare well into the future. Thank you.
Thank you, Professor Buck. You mentioned single payer, and I just want to ask a question about, do you think the passage of the Affordable Care Act put us down a path towards single payer inevitably in 50 years, 100 years, something like that?
I don't know. It's hard. It's hard to weigh in on whether there was an intentional track toward given how much has happened over the last that was the intention. But I do think that, going back to one of the points I made about negotiating leverage, like there's no larger risk pool in the country. And that fixes the fragmentation problem. So if you're looking at it from a perspective of, you want to control costs, you want to make sure hospitals aren't closing, that's obviously got to be on the table. The question is, will we end up there? Can we get there given the concerns that were raised by Blackman and others? I don't know. So I'll sidestep that question.
Thank you. How has the baby boomer generation affected overall healthcare spending in the last 2 decades? And as the baby boomers die, how do you see the marketplace changing?
Good question. So we're in the midst of an unprecedented expansion in Medicare enrollment that started in about 2010 and will level off finally in 2035, somewhere in that vicinity, where we go from about 47 million people on Medicare, actually before 2010. 47 million to 92 million on the Medicare program, almost doubling. At the same time, we are in the midst of a downturn in the amount of people who pay into the program. So 3.4 taxpayers paid for one Medicare beneficiary as recently as about 10 years ago, and the most recent numbers somewhere in the twos now, 2.7, and expected to drop even below 2 into the next decade. So this is a real concern, and most of my writing is in the area of Medicare, so I pay attention to these numbers. I think we're going to start to have these difficult decisions about, do we want to pay for drugs that are clinically equivalent using the same metrics? Do we want to try to pressure providers a little bit better? Do we want to try to limit the available treatments? They're going to be difficult questions to ask. Nobody wants to have these conversations. They're very difficult. In terms of the latter part of the question, you said, will it improve when the die? Well, I don't know. So I think my talk was dark enough before, right? Before, as a singer, that was dark. I don't think you stop and smile a little more or something. No, I don't know. Surveys that ask who costs the Medicare program the most, people who are in their 90s per year. The average 94-year-old costs Medicare something like $16,000. Now, of course, there aren't as many 94-year-olds as there are 65-year-olds, obviously. But just the fact that the population shrinks as you get older doesn't mean that we're actually saving a lot on those people. So it's a good question, but again, I don't know if it's answerable.
Okay. How do you explain the lack of consumer understanding with healthcare, with the fact that no other first world country advertises drugs and explains their effects and risks?
True. I mean, it's a good question. But when you're a health law professor, it's like every time you get questions from colleagues or others who say, I find myself saying this like 10 times a day, healthcare is different. It's just different, right? It's hard, and you can't find that in legal precedent, right? You can't say you got to treat this differently than everything else because it's different. Where's your citation, right? Reminds me of torts class, but it is different, right? And it's different because it's not subject to these consumer tools that we rely on in other markets. Now, I don't think that makes it hopelessly doomed. Like, I think we can impose different types of rules that make it work better in terms of pricing, and like I mentioned, the Physician Sunshine Payment Act, which is part of the ACA, or Nursing Home Compare, or whatever else. Those are all positive. They're not that negative. But you think about it, right? You're in the hospital. You're either in the bed or you're with your loved one, right? It's not like shopping for a TV, right? I mean, think about all the things that come into your mind at that moment, right? You're confused, you're scared, you want to rely on someone who you think is, much more expert than you are, and often is, of course, much more expert than you are, but you're not willing to, it's much less conducive to clinging to this vision of I'm an autonomous consumer, right? You kind of melt. Reminds me of recent writing in the area where even people who have been the most critical of the American healthcare system tell their stories of going to the hospital and getting wheeled in and saying yes to everything, right? Like, in that moment, you're not like, well, I don't know, right? So we need to, what does that mean? We need to put less on the patient in that moment. But there are other institutional tools we need to put in place so that the market works better for them.
Thank you. Does the Affordable Care Act's individual mandate only exacerbate the price of healthcare costs since it gives insurance companies a captive audience? And would a true free market cut down on the excess, or does only the government hold the power to limit that sort of excess?
Well, it goes back to leverage, of course, like I talked about, negotiating leverage. The individual mandate actually holds down the price of healthcare premiums and the fact that, that the ACA missed its targets on enrollment, particularly among young, healthy Americans, is not a good sign for those markets. Right? Without an individual mandate, like for instance, the AHCA replaced the individual mandate with a continuous coverage requirement and then a penalty once you sign up for health insurance. So if you dropped out of the marketplace and then you wanted to come back, you'd have to pay a 30% surcharge for those plans. Well, what does that do? That creates a health insurance pool of very sick people, right? Because only very sick people will pay that 30% better deal to pay that and get health insurance than it is to go without. So the individual mandate, at least I would argue the way it's designed, is meant to hold down price premium increases. Of course, we have to kind of agree on what the bucket of coverage should be, right? And that's where some of the AHCA argument was. Health benefits. Of course, then you run into the problem of, well, the point of insurance is not that everybody uses every single aspect of that care all the time. It's risk spreading. We're all sharing, right? We've moved from an adversarial fairness, or not adversarial, sorry, actuarial fairness model, where, you know, it's only fair if you insure me for my risks, to a community fairness model. We're all in the same boat. So that's the theory behind the individual mandate. You've got to get healthy people in so that you can hold down premiums so you can spread it to more people.
Thank you. And the final question, is it wise to mimic a free market when it's anything but?
You know, another good question, as you know, Professor Huberfeld mentioned in her Q&A, and it's also not that it was binary, like now we're in a government-run system. We've always been in a government-run system. The question is, it has not been clear to the public that the federal government is keeping rural hospitals open, for instance, by funding them through DISH. Or we require hospitals to treat everybody, right, through EMTALA, because we don't want them dying on the sidewalk. That's a societal value that we all cherish. You know, the fact that now we're in this post-ACA phase where it's the government takeover, I mean, that's just false. It's restructuring how we pay for healthcare, right? Instead of hospitals getting DISH payments kind of under the table, we're actually giving people insurance and saying, now you go to the hospital. But that binary, again, it's kind of the lowest common denominator binary that's been allowed to take hold in this debate. It's very politically driven, and it's given a lot of fuel to the political arguments. But it's not true, because we're forcing hospitals to treat people who are uninsured anyway. So the question isn't, should we force people to have insurance? It's how are we going to fund hospitals to keep them open? Particularly in parts of the country where people are really struggling, don't have insurance. What do you do? Do those hospitals close? That's what's happening. Right? So I don't know if I actually answered the question.
Thank you, Professor Buck. Professor Dorocak is a professor at California State University, San Bernardino. Before teaching, Dorocak attended Xavier University, where he earned his bachelor's degree. He continued his education at Case Western Reserve University, where he completed and earned his JD. He completed his education at the University of Florida, where he earned his LLM in taxation. Dorocak is a licensed CPA and is also admitted to practice in Ohio, the U.S. Tax Court, and the U.S. District Court for the Northern District of Ohio. Dorocak's publications include Tax Constitutional Questions in Obamacare, which he'll be speaking on today, and State and Local Government Funding of Healthcare and Retirement Benefits for Employees, Current Problems and Possible Solutions with California Health Benefits as an example. Join me in welcoming Professor Dorocak.
Well, I've seen this done before, so maybe it'll work. Why don't everybody stand up for about 30 seconds to a minute and take a stretch break, right? You didn't get to leave for your break, so because we got another, what, about 40 minutes or so to go. All right. I've seen somebody else do it, so we tried it. Well, faculty, yeah, if you can sit down now, if you would, please. Faculty, students, administrators, guests, distinguished fellow speakers, I've been asked to address the future of Obamacare in light of my past scholarship involving NFIB, and I think it's Sebelius. Thank you for this opportunity. I was hesitating, but I think I'll say I see from my fellow presenters that it is likely that youth has not been wasted on the young. So I'm happy to be part of this forum. In the presence of my very distinguished speakers and audience, I feel like I often do to be something of an interloper here. See, there we go. Because I'm merely the tax professor, right? And in business school, right? Trying to understand how Obamacare was ever constitutional. The fact that this presentation today was not much altered by the events of last week, although I put some references in also for what transpired earlier today. Either the lack of change in this presentation shows that it's timeless or not relevant. I hope it's the former, right? The now retired Professor Eric Jensen, who's at my JD alma mater, Case Western Reserve, although he wasn't there at the time I was, has an article called Critical Theory and the Loneliness of the Tax Professor, right? In that he says issues of race, gender, class have not been addressed much by tax professors who have instead focused on the more narrow and technical issues in business and financial taxation. But he also has said, raise one tax question with the con law person and he's gone. Still, tax practitioners and tax academicians were forced to deal with Obamacare as a tax, as Professor Josh pointed out very clearly, right? First, it was determined to be constitutional as a tax, and then subsequently implemented as a tax. Many have had a visceral reaction, or may have had one. How can the government force us to purchase medical insurance? I know some people tried to parse that question differently. Justice Roberts said, what's next? You know, eating broccoli, which we've seen graphically displayed today. Or I've sometimes not so facetiously said, how about purchasing life insurance? That's a good deal too, and we can start talking about spreading the risk for that. There was a Pew Research survey, I think it was about 2012, on the millennials. You can still get this online for free, and I put it into some of my unpublished writing. Let's try to get into the published stuff, where they asked the several different generations. The first question was phrased in the negative, and this was an addition off the script from what took place earlier today. And it was, and Pew's are relatively respected. I think Pew and Cato are two of the most cited think tanks. Pew asked, when the government does a job, it does a bad job, right, or poor job. That was the first question. Even the silent generation, those that came right after World War II, agreed with that, okay? And so did the baby boomers and the Gen Xers. The millennials did not. Okay? And then their second question was, the government should do more. None of those other generations, now they left the World War II people out because there were fewer and fewer of them in that survey. But when they asked the other question, government should do more, only the millennials said yes to that. So you can plug that into this conversation today. And then what happened in November 2013, there was a Harvard politics poll, and that was the first time the millennials did not favor Obama by more than 50%. And then to bring it back to this presentation today, only about 30%, I think, in that survey said they were going to go out and sign up for Obamacare. And that's the essential, right, for the economics, is getting those young, healthy people to pay. Professor Randy Barnett, who's been referred to today, of Georgetown Law School, has suggested that professors have missed the fact here that no one's forced to buy health insurance, but rather we're forced to pay a tax, right? Well, most tax professors would say, what's the difference? And we'll quote from Justice Stewart a little later. I think it's Stewart on that point. Professor Barnett was arguing for the no small feat, as he called it, of the anti-Obamacare forces prevailing at the Supreme Court in NFIB on the Commerce Clause issue, right? In any event, what constitutional arguments are still available, right, against Obamacare to support this initial gut reaction that some of us may have had that how can this be constitutional? So on my right slide here, where am I supposed to, there we go. Well, I think that's it. My first foray into examining this, right, again, as the tax professor, occurred because of the 2012 NFIB decision. And my approach may have been more unique there. I thought, what constitutional right was being violated? And I came up with liberty as the constitutional right, and I wrote of this in New Hampshire Law Review that came out in 2013. I drew on Justice Kennedy's analysis in Lawrence v. Texas and precursors in Griswold versus Connecticut. Justice Goldberg said in the concurring opinion in, which I prefer, in Griswold, there's the right to be let alone, right? And he even cited the Ninth Amendment. And then there was language in Planned Parenthood versus, or Planned Parenthood of Southeastern Pennsylvania versus Casey, which has been attributed to Justice Kennedy, that choices central to personal dignity and autonomy are central to liberty protected by the 14th Amendment. So I was using that, and people were telling me, well, nobody's written about Lawrence in 10 years, right? That was 2012. And then as soon as that article was done and out, then of course Justice Kennedy wrote the opinion, and it's in my title for today, in Windsor versus United States, and he went back and used Lawrence v. Texas, and then he wrote Huberfeld versus Hodges. So I was a little ahead of him, I thought. Subsequent to the New Hampshire Law Review article, Justice Kennedy wrote Windsor, revising his Lawrence v. Texas, or revisiting, I should say. Next, I was able to write on Justice Kennedy's analysis, and that was on DOMA, right, that the Defense of Marriage Act was unconstitutional in defining marriages between a man and a woman because that violated liberty rights in the Fifth Amendment, right, because it was the federal definition in Windsor. And subsequent to that, Connecticut Public Interest Law Journal picked up an article of mine, and I said, well, why is Obamacare constitutional when DOMA was not, right, if indeed these liberty rights exist? Certainly there are other arguments that Obamacare is unconstitutional. Some have written about the exceptional campaign mounted at the U.S. Supreme Court, right, and arguing that Obamacare could not be sustained under the Commerce Clause, and we saw an excellent presentation today. Others have raised additional arguments, which I attempted to summarize in the Connecticut article, against the constitutionality. And Professor Blackman mentioned on the break that Timothy Sandifer, right, I think he's now litigating for the Goldwater Institute. Yeah, I had something that Cato published recently. And I have cited Sandifer, I've cited Barnett in my articles, but I don't have everything they've written, right, obviously. All right, some of the other arguments, the lack of Commerce Clause support, right? The origination clause that the legislation, we had some of that talked about today already, originated in the Senate, not the House. The uniformity clause, there was some talk of that on the break, that taxes are supposed to be uniform throughout the U.S., and that one is probably pretty clear that it's not, as the rates are different state to state to be covered under Obamacare. There's this direct tax argument, which I try to avoid, right, that if it is a direct tax, it has to be apportioned among the states. At one time, it was thought that the income tax was a direct tax, and therefore the 16th Amendment was needed, right? Although now that argument isn't always believed, I think, anymore. Yeah, exactly. The lack of the enumerated powers, you'll see some references, if we get all the way through my presentation here, to Professor Barnett. And I think Professor Blackman alluded to that he thought there would be at least 5 votes, right, when NFIB went up to say that there wasn't an enumerated power. Well, in the Commerce Clause, they won on that, I think. Scalia argued in his dissent that there was no enumerated power. I've got it later in the paper, but I can't resist bringing it up because under the Necessary and Proper Clause, Justice Ginsburg, of course, said, and Scalia quoted her, that if the federal government perceives a problem, it has the power to solve it. And Scalia said, well, then we have a government of problem-solving powers, not enumerated powers. And then finally, there's this argument that it's a tax, and we had a little bit of discussion of that a little earlier. It's not a tax like any of us in the tax field have ever seen. In the presentation here, which apparently will appear online in the journal, I cite Maximilian Held from Gonzaga Law Review and also Timothy Sandifer from one of his articles in Texas Review of Law and Politics, I think it was, on this fact that this doesn't look like any other tax we've ever seen. And Scalia, it seemed to me, was always careful not to criticize the Chief Justice directly, but that didn't stop him from criticizing Justice Ginsburg directly, right? I tell my students, if you like big government, then Justice Ginsburg should be your hero, right? Scalia said, as I mentioned a little earlier, in his dissent, that, oh yes, we could have a credit for putting in energy efficient windows. We've seen that. We have tax credits like that on all these energy provisions. They've been in the federal tax law in California, where I currently reside. We have some credits like that. But he didn't think he just stopped there, right? However, on the other hand, the Chief Justice said in his majority opinion that we could have a tax on not putting in energy efficient windows, okay? If somebody's seen one of those, please let me know, all right? Now, and then the question is, what kind of tax is it? And they get into this excise tax question, so I'll be interested to see what Sandifer said about the excise tax. I mentioned on the break, there's a case, I think it's called Murphy versus Commissioner, or Murphy versus United States. It's in the tax books. She was a federal employee in, you may know this case, in D.C., and she sued for some sort of harassment, and she claimed emotional distress. Now, the exclusion in the tax law, I don't remember the code section number, I know it's in the 100s. The exclusion, you can exclude everything that you get on a judgment or a settlement if there's physical injury. But she was alleging emotional distress. And I think that case went up twice to the D.C. Circuit. And the first time they said, oh, we're going to agree with her argument that she's just being made whole. There's no income here. Therefore, the tax law is improperly written here, right? Maybe unconstitutional. I have to go back and look at all their arguments, right? Because there's no income here to be taxed. So the second time it went up to the D.C. Circuit, as I remember, I'm going to have to go back and look again, Murphy, just like Murphy's Law, they went off on something else. They said the Congress could pass a tax. It could be embedded in the Internal Revenue Code, and it doesn't have to be an income tax. It can be a tax under, it sounds like, yeah, and I think they called it an excise tax, because almost every, excise taxes, at least the way tax people understand them, are transfer taxes. So even the estate tax and the gift tax are transfer taxes, excise taxes, at least the way we've kind of, we usually, as Professor Jensen said, we usually don't get into these constitutional law questions. The focus of my comments today will be on how the legislation may have violated liberty or liberty rights. All right, in Citizens United versus FEC, not only did Justice Kennedy, Justice Kennedy decide that corporations and labor unions had First Amendment free speech rights, right, thus laying the foundation for the super PACs, he also employed, some say resuscitated, the constitutional conditions doctrine. I got criticized for using that one in the New Hampshire Law Review article also. The doctrine states, the constitutional conditions doctrine, that a benefit, all right, including a tax benefit, cannot be conditioned on the non-exercise of a constitutional right. And here's my reference to Justice Stewart, Perry versus Sinderman. Stewart said that allowing a benefit to be conditioned on the non-exercise of a constitutional right would allow the government to produce a result it could not command directly. All right, in Citizens United, Justice Kennedy stated that the benefit of the corporate form of organization could not be conditioned on the corporation's forfeiting its First Amendment free speech right. Right, to speak in political elections by making unlimited expenditures through third parties, although you can still limit contributions directly to candidates. Justice Kennedy cited to Justice Scalia's dissent in another case, Austin versus Michigan Chamber of Commerce. the state statute there criminalized the conduct, right, of the corporation. But Justice Kennedy stopped literally just short of citing Justice Scalia's citation to another case, Spicer versus Randall, which is in the title of this article. All right, Spicer versus Randall. There we go. U.S. Supreme Court said that a California property tax exemption could not be conditioned on a veteran's requirement to swear a loyalty oath. I believe it was Justice Brennan wrote the majority opinion here, because the loyalty oath requirement would violate free speech. And so, yes, this is another tax case involving a constitutional issue, right? I had familiarity with Spicer because of Citizens United, because Kennedy just stopped short of citing Spicer. And I had written an article about Citizens United, which kind of formed the basis for the New Hampshire article, with Professor Lloyd Peake, one of my business law colleagues. I teach tax, he was teaching business law, and we published that article on Citizens United in the North Carolina First Amendment Law Review. Okay. Question arises, right? Okay. Can we use Spicer and Citizens United, at least that's where I was in the summer of 2012, in questioning the Obamacare constitutionality? The question is, despite maybe a gut reaction by some of us on unconstitutionality of Obamacare, upon the non-exercise of what constitutional right would the benefit of Obamacare be conditioned, right? You're getting a benefit of what? Not having to pay the tax, okay? But what right are you giving up? Okay? In a eureka or aha moment, it occurred to me that liberty might be the constitutional right. And I had approached this, as you might be able to see as I moved from the free speech article, not as an ideologue, but as a traditional legal scholar. I had some vague awareness that there were other people out there arguing liberty rights based on the Constitution, the Declaration, the Preamble, the Ninth Amendment. I just elevated him. Professor Barnett has said once he got tenure, he felt free to argue the Ninth Amendment. Due Process Clause of the 4th and 15th Amendments, Equal Protection Clause, all these were sources, right, of these liberty rights. Justice Scalia, in his dissent in NFIB versus Sebelius, mentioned private conduct, but he more explicitly relied on the enumerated powers of the federal government, as we've mentioned, and the reservation of power to the states by the 10th Amendment, which was brought up earlier today. Okay, I think I'm on the right slide here. What may have informed my insight concerning liberty as the burden constitutional right, I documented this in the New Hampshire article, was an overnight Revolutionary War reenactment outing at the insistence of my then 5th grade son. It was in Southern California in an establishment called Riley's Farm. All this got cited in New Hampshire's Law Review. The evening meal at the overnight stay in the Revolutionary War era pub featured the patriarch of the family farm delivering as Patrick Henry the famous "Give me liberty or give me death" speech. Right? And the law students at New Hampshire, it must be the state motto, that's a live free or die, right? Yeah, they let me keep the quote in that Patrick Henry did not say, give me health insurance. Right? I have to have some fun with it, right? Must be down here. There we go. All right. So in this part of the presentation here, and I think I'm running all right on time, we'll talk about Lawrence, Planned Parenthood of Southeastern Pennsylvania, Griswold, Windsor, Obergefell, right? Okay. Are there Supreme Court cases offering precedents, right, for finding liberty or liberty rights? And why not for the rest of us, right? Yeah. Even before Windsor and Justice Kennedy's revisiting of his analysis in Lawrence v. Texas, there was Lawrence, and particularly Griswold, and Planned Parenthood of Southeastern Pennsylvania, all of which offered language, right, which might be used to find liberty or liberty rights. And I think it was also in the New Hampshire article, I said, this is all very pretty language. But then I quoted Woody Allen, who said about baseball, it's very beautiful and it means nothing, right? Unless we can use this language for something. Looking at some of these cases, in Lawrence, Kennedy, writing for the majority, held a Texas statute prohibiting same-sex sodomy, right, unconstitutional because it violated liberty. Kennedy quoted from Justice Stevens' dissent in Bowers versus Hardwick, which was the predecessor case, and that case had upheld a similar statute. Right? Justice Stevens stated in part, individual decisions concerning the intimacies of their physical relationship are a form of liberty protected by the Due Process Clause of the 14th Amendment, right, in Bowers. Kennedy wrote in the introductory language in Lawrence, liberty protects a person from unwarranted government intrusion. Liberty presumes an autonomy of self. The instant case involves liberty, right? Yeah, I sometimes still run into people who tell me that Lawrence is about privacy, right? Yeah, sort of like Griswold. Yeah. But Kennedy said this case involves liberty. Justice Kennedy also quoted from Casey in Lawrence, these matters involving the most intimate personal choices the person may make in a lifetime. Choices central to personal dignity and autonomy are central to the liberty protected by the 14th Amendment. Certainly medical and medical insurance decisions involving whether to purchase medical insurance or not are among these most intimate personal decisions, right? Professor Zack had said, yeah, if we're at the hospital, right? Yeah, these are very personal, intimate decisions. Professor Barnett has written of Casey, in a portion of the joint opinion commonly attributed to Justice Kennedy, the court shifted the focus from privacy to liberty and even relied on the Ninth Amendment to do so. As I recall, Casey is the Supreme Court revisiting Roe versus Wade, right? And so they got back to some of those arguments. Griswold was, of course, the contraception case, right? It appears that Professor Barnett was thinking that the court relied on the Ninth Amendment. I couldn't find that when I went back to search the opinion, that specifically that the court used the Ninth Amendment in Casey. Griswold, right? In the concurring opinion, Goldberg, and I like that concurring opinion, wrote, quoting Justice Brandeis, the makers of the Constitution conferred as against the government the right to be let alone, the most comprehensive of rights, the right valued by civilized man. That's what a lot of these people, I think, despite the colorfulness of their displays at the court, right, what they might be arguing for. Okay, Windsor and Obergefell, right? Two Supreme Court cases involving same-sex marriage. Now, some people might say, well, they want to confine the language in these cases then to same-sex marriage or same-sex couples. Justice Kennedy appears to have continued his liberty or liberty rights analysis. And I think you can use this to argue that Obamacare and similar legislation is unconstitutional. Okay. In Windsor, right, Kennedy writing for the majority, holding unconstitutional Doma's definition of marriage between a man and a woman. That's the federal definition, right, that the Republicans passed. Kennedy said, the power which the Constitution grants it also restrains. This is Windsor. And though Congress has great authority to design laws that fit our own conception of sound national policy, that echoes the beginning of NFIB, right? It cannot deny that liberty protected by that liberty is protected by the Due Process Clause of the Fifth Amendment, right? Because this was a federal definition. Writing midway between Lawrence and Windsor, Barnett argued that a new analysis had emerged, distinct from traditional due process and equal protection, you know, with those tiers, TIERS, both raised by Justice Alito, the traditional due process and equal protection. I'll mention a little later again. Professor Barnett said, in other words, Lawrence did not purport to assess the degree to which the statutory prohibition may have met a legitimate state purpose. Instead, it rejected the open-ended conception of police power and found that the purpose of the statute is illegitimate or improper. This is analogous to finding at the federal level unconstitutional because however effective it might be, a federal statute, its purpose is not among the enumerated powers, right? Article 1, Section 8. Okay. Now I added a note here. I said, I thought Windsor spoke most clearly to the unconstitutionality of Obamacare, and I used this comparison in the article on Windsor that I wrote for GMU, George Mason University's, one of their journals. Just as Windsor same-sex couples could not be forced to marry opposite gender partners to enjoy the estate tax marital deduction. That's what they were arguing about, right? $300,000 plus of estate tax savings because they wanted the marital deduction. Okay, and the court said, well, you know, really can't be forced to marry opposite gender partners. Then I extended that. I believe individuals should not be forced to purchase health insurance, right, to avoid a tax. Obergefell, right? Justice Kennedy then held that, writing for the majority, right, that the state prohibitions on same-sex marriage were unconstitutional. And aside, Justice Scalia predicted that, right, in the dissent in Windsor, that was next, and it was next. The Constitution, this is Kennedy writing in Obergefell, the Constitution promises liberty, right, to all within its reach, a liberty that includes certain specific rights that allow persons within a lawful realm to define and express their identity. The petitioners in these cases seek to find that liberty in marrying someone of the same sex. These considerations lead to the conclusion that the right to marry is a fundamental right inherent in liberty, and under the due process and equal protection clauses of the 14th Amendment, couples of the same sex may not be deprived of the right of that right and liberty. There we go. In my most recent manuscript, Willamette Law Review accepted it and is publishing. I argue that an attempt to revoke the tax-exempt status of churches, right, who are opposed to same-sex marriage. There's an article out already about that. Could the tax-exempt status of churches like the Catholic Church, the Mormons Church be could their tax-exempt status be revoked because they don't are not in favor of same-sex marriage, on the argument that it's now a national policy that's well established? Well, the problem with that is that the IRS is probably not going to raise this challenge. They have I think it's they have a document out. I think it's a revenue procedure. So I have it cited here. I have it cited, in which they are not doing much with auditing churches. And private parties are probably going to lack standing. Some of you probably have looked at that when eventually they denied private black parents standing to sue the schools that were discriminating, right, and try to get their tax-exempt status revoked. Okay. I argued in this article that Willamette will publish that, okay, well, I don't think they're going to be able to revoke the tax-exempt status, even if we could find somebody who could make the argument, whether the IRS or a private litigant, because of free exercise, because of religious freedom, or because of liberty rights argument. And you can tell what a tax professor I am. I'm sitting there thinking, okay, well, what's the policy reason that, I'm thinking as a tax person, right? Well, they've got this tax-exempt status. Now we're arguing there's a national policy established of same-sex marriage. What's the policy reason on the other side? I'm not thinking like a common law person. Oh, the First Amendment, right? Yeah, the Free Exercise Clause, or Religious Freedom Reformation Act. And that's Burwell, right, versus Hobby Lobby. The decision there, the case likely shows that Obamacare can be challenged for constitutional violations, although that case was based on the Religious Freedom Restoration, I may have a typo in there, Restoration Act rather than the First Amendment. We're done. Time, we're okay yet? All right, I've only got another part and a conclusion, right? This is where I just briefly go on traditional due process and equal protection analysis, right? As I say here, in this forum, I don't believe I can do justice to that traditional analysis. Undoubtedly, many are familiar with it. However, there is an aspect of substantive due process here, which might be illuminating. Professor Barnett has criticized traditional due process and equal protection, yet Timothy Sandifer has defended substantive due process, possibly returning to its origin in Calder versus Bull. Daniel J. Crooks III, right, in a recent article in my citation here, let's see if I've got it, Charleston Law Review, he has said that Windsor is best understood as a Lawrence brand liberty case, all right, distinct from the court's traditional equal protection and due process precedents. The court's substantive due process jurisprudence, this is Crooks again, the court's substantive due process jurisprudence is esoteric and equally incomprehensible to even the keenest minds in the legal academy. Right? And like I say, I'm just a tax professor. As I review in the Connecticut Public Interest Law Journal, Justice Alito in the Windsor dissent, as many of you may be familiar with, deals with traditional jurisprudence of due process and equal protection and the tiers of scrutiny. Okay. Mr. Sandifer, right, argues that the Constitution imposes limits on laws that the legislature can enact, and the content of those limits can be understood only by considering what the Constitution was written to accomplish. Now that's Sandifer. But then he quotes from Justice Samuel Chase in Calder versus Bull. There are certain vital principles in our free Republican governments which will determine and overrule an apparent flagrant abuse of legislative power, to take away that security for personal liberty, for the protection whereof the government was established. Beautiful language. Mr. Sandifer has written elsewhere, understanding the Constitution requires reference to more permanent principles than mere long-standing convention. And he's talked about the contrast between liberal and conservative originalists. One more reference here. Let's see, there's our Calder versus Bull, the beautiful language. Professor Barnett has talked about original meaning and original intent, which may echo what Mr. Sandifer is calling tradition versus more permanent principles. And the conclusion, how are we doing? Good on time, all right. Okay. When I began this journey, right, summer of 2012, okay, trying to understand the legality and the constitutionality of the tax imposed by Obamacare, I didn't know where this was going to lead with many of the articles I've written. Others in the tax field began where I had, and I remember the day that the opinion came out, the Supreme Court opinion, CCH, Commerce Clearinghouse, which is a big tax publisher, came out with online and then to their still paper subscribers, you know, an analysis of the decision. But it didn't look like a tax that any of us had seen. I thought that the Supreme Court, before the decision, was going to hold Obamacare unconstitutional on some ground, thinking as a tax professor, probably. I thought Governor Romney might deny, I could call him professor, President Obama's second term, and that might stop the implementation of Obamacare. There was a reference to that earlier today. Justice Scalia, right, who we talked about a bit today, said in his dissent in NFIB that the federal government could provide a tax credit, right, for purchasing health insurance, but not a tax for not purchasing it, right? And if Justice Ginsburg were correct, the federal government was a government of problem-solving powers, not enumerated powers. Justice Roberts, though, had said in his majority opinion that there could be a tax for not installing windows. Then my timely reference here, right, the Republicans and their way to the intended repeal and replacement, with only some concern for a constitutional basis. This might be one of the lone voices here in the wilderness, then mine and some others. The Republicans, though, did attempt to, in their legislation, the HCA, repeal the individual mandate by removing the tax for failure to purchase health insurance. And as we saw in that executive order, the way I'm reading that, Trump is suggesting that the administrative agencies, and there's three involved here, the IRS, the HHS, and is it DOL, I think? Treasury? No, that's the IRS. I think it's DOL and HHS. One of the articles I wrote, there's tens of thousands of pages, and they had a page count on the regs. In the tax area, we've still been talking, and it's 30 years now, about the 200 pages of regulations they wrote about passive activity losses. That's only the tax people can come up with passive activity, right? But there are 200 pages. Oh, we've been talking about that for 30 years, right? And this is tens of thousands. Let's find my place here again. Oh, yes. Yeah, Justice Scalia. The Republicans did have a premium on the surcharge for running into the health market later. 30%, I read something where originally they wanted to make it 50%, but they didn't think they can get that through. That was in Scalia's dissent in NFIB, that credit for buying tax, okay, or surcharge and entering the market later, that's all fine. I think the founding fathers would think Scalia was closer to the mark here. I'm getting the 1 minute warning, so thanks for this opportunity. I think essentially the conundrum here is that which was posed by Benjamin Franklin. Let's see if I can find that. Back one. Yeah, it's really the way he put it, those who can give up essential liberty to obtain a little safety deserve neither liberty nor safety. That's the conundrum. And I've been thinking, if people paid more attention to the Obamacare and the DOMA arguments, they might become more conscious of liberty. So thank you for this opportunity to discuss a topic which has become quite dear to me lately, and maybe not surprisingly, liberty. That's the unpublished manuscript. Thank you.
Thank you. Now we have time for a brief Q&A, and if you have any questions, just don't be afraid to shout them out. But I'll get the ball rolling. Doesn't every tax kind of implicate a liberty interest? And what makes the Affordable Care Act tax different than?
Yeah, if you just take it as a tax, we get back to the tax and spending clause. But if you look at it in terms of some of this other, I say in the conclusion, I skipped over that part, that all these cases don't exist in a vacuum. All these were going on at the same time. The Obergefell versus Hodges, the Windsor versus the United States, the Citizens United versus FEC, right? And that's where I started on that train of, well, wait a minute. If you can impose a tax to get somebody to give up a constitutional right, right? That's Justice Stewart in that Sinderman case, right? You're going at it indirectly, what you can't do directly. Yeah, so it's not just the fact that there's a tax, but there's the fact that you get out of the tax if you do what we say, and that is buy the health insurance, right? Just like you get the marital deduction if you do what we say, marry an opposite gender person.
Thank you. Are there any other questions for Professor Dorocak? See no other questions. Thank you, Professor.
Thank you.
Okay, thank you everyone for coming. That concludes our program for today. I appreciate you all taking the time, and I'd like to thank our speakers one last time. Thank you very much.